Hello everyone. I hope I am audible and visible to you all. Just let me know in the chat box that if I am audible and visible. Just let me know, guys. Hello everyone. I hope I am audible and visible to you all. Just let me know in the chat box. Okay. So, before we start this session, I hope you all are doing fine and upbeat about your upcoming exam. And I think you all very well aware that the new edition of Bailey and Love has come up. And INICET exam also, you know, at the same time follows a specific pattern. There are few topics which are always in the scheme of things when it comes to ask a question on surgery, you know that. And if there are updates related to that particular topic, obviously we have to know that. So in this particular session, I have tried to incorporate all those updates which are important for us to know before our upcoming INICET exam, because there are few topics which are very, very important for INICET per se. And in those topics, there are some updates also. So we will be talking about those updates. I will be continuously looking at the chat box here. So if there is any doubt or any confusion you have, you can always free to ask me. You know that whenever those who have attended my classes would know that I'm one of those who like those interactive sessions. So you can ask any question without any fear or any scare, because this is your opportunity to clear your doubts also. So we are going to get started. First of all, we know breast is a very, very important topic as far as INICET exam is concerned, and it becomes all the more important for a reason that the chapter on breast is contributed by the AIMS faculty. So it becomes very important for us to know the updates which have come up in that breast chapter. Many of things we have already discussed in our classes. We have in this I have handpicked few important updates for our upcoming exam. The all updates which are there in Bailey and Love we have already recorded in our app too. But then I have handpicked some important updates which I feel are the updates which we need to know before our upcoming exam. And in breast, we know very well that breast malignancy is always a very important topic. So what are the updates which are there in the breast malignancy? Let us know that. First of all, there are updates on BCT. See, I will be sticking to the updates. I'm presuming here that the things related to the topic you know already. Some things which there is a confusion, I will try to sort that confusion out, but then I'll be majorly sticking on the updates. We know that in BCT has three components: wide excision of the lump. We very well know BCT is a combo of three things: wide excision of the lump with axillary dissection and radiotherapy to the breast. When these three things are done together, we call a procedure a breast conservative treatment, right? Now, in this wide excision of the lump, we have talked about in our classes already though, but then there is something which we have to add on to that. This, what is now incorporated in the latest edition of Bailey and Love, these are the things we were already doing, but then since they have incorporated here, so we need to know that. So if imagine this is the breast, and we are excising this lump here. We know that outer upper quadrant is the most common site of any pathology in the breast by virtue of the fact that the majority of the breast tissue is present in the outer upper quadrant. So we excise this lump with a wide margin, and 1 centimeter wide margin we take here. Now what we do here, we have talked about in our classes that what is a persistently positive margin, but then we have to know now further one thing more, that once this lump is excised, there is a normal tissue around it, excised also about 1 centimeter. So this whole specimen will be sent to the pathologist. Now, when we send this specimen to the pathologist, we are supposed to orient this specimen. This is the latest here. To orient this specimen, the present guideline says that apply a suture on the superior margin and the lateral margin. Now, how the pathologist would know that it's a superior margin or a lateral margin? It is said that the pathologist knows this when the specimen reach. How he knows? That a short length suture we always place on the superior margin. Short length suture, we apply a suture and cut the suture and keep the length of the suture short. So this short length suture is kept on a superior margin. A long length cut end of the suture will be kept on the lateral margin. Now, once we got these margins labeled, superior and lateral got labeled, medial and inferior obviously easily now can be made out. So this specimen will be sent to the pathologist. Now, pathologist is supposed to examine this specimen under frozen suction biopsy, and we will be waiting in the operating room, right? Now, if the pathologist calls me and tells me that the margins which you have sent, the normal tissue which I have sent of 1 centimeter around it has no malignant cells on it, he will say, we know that it is called microscopic negative margin, right? This is called a microscopic negative margin. And we also know that the term used for this also is no ink on tumor. We have discussed in our classes already that. Now, if by any chance, now this is something important, if by any chance any margin, imagine this margin, the pathologist found a malignant cell, so he will label it as a inferior margin. I found a microscopically malignant cell present there. So the term used will be the ink on tumor. So he'll call me that the inferior margin, because the margins are labeled, he will say that on the inferior margin there is an ink on tumor. Now, what am I going to do? I'm going to take another 1 centimeter margin from the margin which was told to me. It was in this example I've given you is on the inferior margin, that any margin can be positive told to me. So if the any margin, whatever margin told to me is positive, I'm going to take 1 centimeter margin from that again. So this 1 centimeter margin which I have taken is called cavity shaving. This is called a cavity shaving. Now, this 1 centimeter margin from wherever it was positive, I'll again send it to the pathologist. Now, if the pathologist says that this time the margin is negative, that is, there is no ink on tumor, I will now close this specimen. If the previously he tells me that the margin was negative, I would have closed the defect which I have created. Now, if the margin turns out to be negative on second attempt, then I will close the defect which I have. But if he says that the margin is still positive, first of all, this is a definition of a persistently positive margin. This we already knew, that 2 times margin positive is a persistently positive margin, and once there is a persistently positive margin, we are supposed to convert this procedure to MRM. We are supposed to convert this procedure to MRM. We know that. Now, what is important further in this? Now, in certain cases, so if the persistently positive margin is there, 2 times positive margin, we are supposed to proceed to MRM. Now they say we have another option also in these cases when the margin turns out to be persistently positive, which is called skin and nipple areola complex sparing mastectomy. In our videos, we have talked about this surgery, but then now this has been incorporated in the latest edition of Bailey, so we need to further highlight on that. So we can also do a cosmetically better surgery, that is, instead of MRM, in MRM we know we take a ellipse of a nipple or complex and the skin overlying the lump also we excise, but then in the skin and nipple areola complex sparing mastectomy, we don't excise the skin and the nipple complex part, just excise the breast part. So this is called skin and nipple areola complex sparing mastectomy. But this skin and nipple areola complex sparing mastectomy we can only do, this is important for us, if the lump is more than 1 centimeter away from the skin. If this lump is more than 1 centimeter away from the skin and more than 2 centimeter away from nipple areola complex. So the question which can be asked in your exam is that a patient had a persistently positive margin and the lump is more than 1 centimeter away from the skin and more than 2 centimeter away from the nipple complex. What type of mastectomy you will prefer? So in such cases now we prefer a skin and nipple areola complex sparing mastectomy. So this is a cosmetically better type of mastectomy over a MRM, the conventional MRM which we used to do. So but then this can only be possible when this criteria is met, right? So persistently positive margin, what is persistently positive margin is important for us. Short superior, long lateral is important for us, and then skin and nipple complex sparing mastectomy when to be done is important for us. Then another update which has come up here is, which we were also earlier doing, but then this is something now is important for us since it is there in the Bailey. What we used to do was that imagine after wide excision of the lump. Now this is important. After the wide excision of the lump, the volume of the defect which got created. Imagine there was a one-time wide excision was done and the margin turned out to be negative. So this was the volume of the defect, imagine, got created. Or if the margin turned out to be positive, we have to take 1 centimeter, one more margin in the cavity shaving part. So the defect is now, imagine this much. So it can be either after 1 time excision or it can be either after a 2 time excision. But now imagine this is the defect. Now the present guideline says if the volume of the defect which got created is less than 20% of the volume of the whole breast. If the volume of the defect got created is less than 20% of the volume of the whole breast, the guideline says you should mobilize the remaining part of the breast tissue. You can mobilize the remaining part of the breast tissue to fill this defect and close this defect. So when we mobilize the remaining part of the breast tissue and cover this defect, mobilizing the remaining part of the breast tissue and cover this defect, this kind of a procedure, first of all we should know, is called a volume displacement surgery. This is called volume displacement surgery, or it is also called a level 1 oncoplasty. So there can be a question in exam that what is a level 1 oncoplasty? So level 1 oncoplasty, and when can it be done? Level 1 oncoplasty is a volume displacement surgery where we mobilize the remaining part of the breast tissue to fill the defect. This we can only do when the volume of the defect is less than 20%. But if by any chance the volume of the defect got created after 1 time excision or twice excision is more than 20%, the guideline says that if you try to mobilize the remaining part of the breast tissue, you may be able to mobilize the remaining part of the breast tissue to cover this defect, but after mobilizing the remaining part of the breast tissue, the breast will get disfigured. So the whole purpose of a cosmetically advantageous surgery, that is BCT, will get defeated. So in such cases, don't try to mobilize the remaining part of the breast tissue. Just fill this defect with a flap or a autologous fat from the patient's body. So when we cover the defect with a autologous fat or a flap from the patient's body, it is called a volume replacement surgery. It is called a volume replacement surgery or a level 2 oncoplasty. So when is a level 1 oncoplasty done? When is a level 2 oncoplasty is done? is something latest and something important for us, right? Less than 20% volume displacement, more than 20% volume replacement. So this is a volume displacement and volume replacement part in the BCT which we have to know. Then comes further on the BCT is that in patients of early breast cancer, we do a axillary dissection if the indications of sentinel lymph node biopsy are there. We know what are the indications of sentinel lymph node biopsy. We know that what are the contraindication of sentinel lymph node biopsy. So sentinel lymph node biopsy, on the basis of sentinel lymph node biopsy, we decide on a axillary dissection. If the indications are existing and the contraindications are not existing, now we proceed to axillary dissection only after doing a sentinel lymph node biopsy. And the various aspects of sentinel lymph node biopsy we already know about, what are the various types of dyes used, the radioisotopes and the plain dyes, isophane blue, the technetium 99 labeled, the colloid sulfur, we know that. Now what is the latest in the sentinel lymph node biopsy? They say that we can also use a fluorescent dye. To do a sentinel lymph node biopsy, we can also use a fluorescent dye. Now, what fluorescent dye can be used? Because in AIIMS, INICET, sentinel lymph node biopsy is a very favorite topic of the AIIMS examiners. So we can use a fluorescent. We can use fluorescent, and we can also use indocyanin green. Now, when we are using a fluorescent or a indocyanin green, we have to use a infrared light to the blue light to see this, the fluorescent light actually to see these fluorescent dyes going into the lymph node. So for fluorescent, we use a blue light of a wavelength of 480 nm, and in indocyanin green, if we are using, we use an infrared light of 780 nm. So this is a wavelength. And another important point, this is something important I have talked about in our classes earlier too, that in pregnant female, can we do a sentinel lymph node biopsy in a pregnant female? This is the latest here which is incorporated in the Bailey. In pregnant female, sentinel lymph node biopsy can be done. But if you are doing a sentinel lymph node biopsy in a pregnant female, this is something interesting. We should use a low dose radioisotope dye, but we should not use isophane blue and a methylene blue. We should not use a isophane blue and a methylene blue. So sentinel lymph node biopsy can be done in a pregnant female, but if you are doing a sentinel lymph node biopsy in a pregnant female, we should use a low dose radioisotope dye, not isophane blue or a methylene blue. Now, then comes another very important update. See, you all very well know that stage 3 carcinoma breast is also called as a locally advanced breast cancer. And stage 3 is further divided into 3A, 3B and 3C. And we all hopefully know the treatment of 3A, 3B and 3C. You know that the treatment of 3A is primarily MRM, followed by chemo, followed by radiotherapy, plus minus hormone therapy, plus minus a monoclonal antibody, depending on ERPR if positive, or HER2/neu is positive or negative. Depending on that, the ERPR positive, the hormone therapy will be added, monoclonal antibody will be added if HER2/neu is positive. In stage 3B and 3C, we offer a neoadjuvant chemotherapy. We offer a neoadjuvant chemotherapy followed by MRM, followed by chemo, and followed by RT is a treatment of a stage 3B and 3C breast cancer, right? Plus minus hormone therapy, plus minus monoclonal antibody, we already know that. Now, in certain cases of 3A, if the patient wants to conserve her breast, we know that if the patient is very keen, we should not encourage her to go ahead with BCT, but then we can think of offering a BCT to a patient who has a stage 3A breast cancer also. But if we are offering a BCT, we are supposed to give a neoadjuvant chemotherapy first. Then If the response is good, then we go ahead with the BCT and then the chemo and then the RT, the same thing will be there. Now, what is very important here to notice that whenever we are going to give a neoadjuvant chemotherapy, first of all, the total number of cycles, we know this, we have discussed in our classes too, the total number of the cycles of chemotherapy which we give in breast malignancy are 6 to 7 cycles. 6 to 7 cycles of chemotherapy are supposed to be given to a patient of carcinoma breast, and these 6 to 7 cycles are 21 days apart. Right? We commonly use a ACT, we know that, or we can use CAF also. Right? Cyclophosphamide, adramycin, 5-fluorouracil also we can use adramycin, cyclophosphamide and taxane based chemotherapy also. But then we are going to give a 6 to 7 cycle, and these cycles are 21 days apart. Right? Now, what is incorporated in the latest edition of this we always follow. After when we give a neoadjuvant chemotherapy, what is neoadjuvant chemotherapy? What is a adjuvant chemotherapy? We know that whenever any adjunct treatment is given prior to primary modality of treatment, it is called a neoadjuvant treatment. Whenever a adjunct treatment is given after the primary modality of treatment, it is a adjuvant treatment. Now, in breast, since the primary modality of treatment is surgery, the chemotherapy if given prior to that, it will be called neoadjuvant chemotherapy. If the chemotherapy which is an adjunct treatment, if given after that, it will be called a adjuvant treatment. So any treatment if we give prior to a surgery, it will be called a neoadjuvant treatment, right? So neoadjuvant systemic therapy, here we commonly give a neoadjuvant chemotherapy in stage 3 of cancer breast. In some stage 2 early breast cancer also sometimes we give a neoadjuvant chemotherapy, but primarily in stage 3 we give a neoadjuvant, in some cases here and in all the cases here. Right? Now, whenever we are giving a neoadjuvant treatment, we are supposed to assess the response of this neoadjuvant treatment in a given patient, and on the basis of the response we get, we are supposed to modify our treatment. So what are the various types of responses and how are we going to modify the treatment after the response is something very important for us to know now. So after second cycle of the chemotherapy once gone, now what is important is once 2 cycles are given, second cycle was given 3 weeks after the second cycle of the chemotherapy, we are supposed to check the response. Now, this response is categorized into 4 categories. There can be a complete response, there can be a partial response, there can be a stable disease, there can be a progressive disease. So after second cycle, the 3 weeks after the second cycle of the chemotherapy once given, we are supposed to assess the response. The response is categorized into complete response, partial response, stable disease and progressive disease. Now, how we say there is a complete response, how we say it's a partial response, how we say it's a stable disease, how we say it's a progressive disease is something very important. This is decided on the basis of a criteria called a RECIST criteria. This is decided on the basis of a criteria called RECIST criteria. Now, what is RECIST? This is important here. RECIST is response evaluation of chemotherapy, response evaluation of chemotherapy in solid tumor, response evaluation criteria, not chemotherapy, response evaluation criteria in solid tumors. Response evaluation criteria in solid tumors. So this RECIST divides the response into 4 categories: complete response, partial response, stable disease and a progressive disease. When will you call the response is a complete response? We will say the response will be complete if the target lesion, that is tumor, the target lesion is not detectable at all, when the target lesion is not detectable at all, be it on clinical examination as well as on imaging. If the target lesion is not seen completely, be it on clinical and imaging, it is called a complete response. The partial response term is used. This is important. The partial response term is used when more than or equal to 30% reduction in the maximum diameter of the target lesion happens. When more than or equal to 30% reduction in the maximum diameter of the target lesion happens, it will be called a partial response. Stable disease is a term used when the less than 30% reduction in the maximum diameter of the target lesion happens, and the progressive disease term is used when more than or equal to 20% increase this time, increase in the maximum diameter of the target lesion happens. When a more than or equal to 20% increase in the maximum diameter of the target lesion happens, even after a neoadjuvant systemic treatment. Now, first of all, we have to know what are the response categorization in RECIST. What is complete response, what is progressive disease, what is stable disease, and what is partial response. Now, how our treatment is going to change in a given patient of a carcinoma breast is something important. So after the 3 weeks of a second cycle of a chemotherapy, we if got a complete response or a partial response. If we get a complete response or a partial response, important. The guideline says finish all the cycles of the chemotherapy. 2 we have already given, remaining 4 or 5 are left. So guideline says finish all the remaining chemotherapy here itself, all the remaining chemotherapy upfront itself, and after finishing, it's a very good thing, the response we get such a good response. So after finishing all the cycles, now offer a surgery. If it was a BCT planned, it was a stage 3A patient, we'll go ahead with the BCT. If it was MRM, 3B and 3C, we'll go ahead with MRM. And after that, now we will give a radiotherapy because chemotherapy is all given. And then plus minus hormone therapy, plus minus monoclonal antibody will be given. But if there is a stable disease or a progressive disease, if there is a stable disease or a progressive disease, this is important. Now the guideline says you got to know that this chemotherapy which you have started, the patient is not responding, or even with the chemotherapy the disease is progressing. So abandon this chemotherapy, don't give any further chemotherapy now, offer a surgery. Now in this scenario, if it was a stage 3A patient, we will not be doing a BCT, we will be offering a MRM there. And in 3B and 3C, we will be anyways offering a MRM. Now after this surgery, the surgery is done, the cycles are still remaining because we are supposed to give 6 to 7 cycles. Now the remaining cycles, we will give a second line chemotherapy because we got to know that the first line chemotherapy, the patient was not responding. And after the second line chemotherapy got over, the rest of the treatment remains the same. So what is important for us to know, let's get the recap. Whenever we give a neoadjuvant treatment in a patient of carcinoma breast, we are supposed to assess the response. The response is assessed on the basis of a RECIST criteria, response evaluation criteria in solid tumors, right? Now, this RECIST criteria is applied after 3 weeks of a second cycle. Once the second cycle is over, 3 weeks after that, the RECIST criteria has to be seen. Now, if we got a complete or a partial response, we have to finish all the remaining cycles of the chemotherapy upfront, and then we have to proceed with surgery. If it was a stage 3A patient, we will go ahead with BCT. If it was a stage 3B and 3C patient, we will go ahead with MRM, and then the rest of the treatment remains the same. Now, if it's a stable disease or a progressive disease, is we will stop the chemotherapy here. Patient cannot be offered a BCT here because the patient response was either a stable disease or a progressive disease. So we wanted to decrease the size so that we could do a BCT. So we could not do that. So we have to offer a surgery that will be MRM, and after MRM, this chemotherapy can't be given. We give a second line chemotherapy and then rest of the treatment remains the same. So what we can also, if we can observe it carefully, we can see here that what neoadjuvant treatment actually offers us. What a neoadjuvant treatment actually offers us in any given cancer. Whenever we give a treatment, adjunct treatment prior to a primary modality, what actually it offers us, which was a last year NEET question also, we can see it is done to decrease the size of the tumor or downstage the disease. It is done to downstage the disease. And second thing, it also tells us the response of the chemotherapy. We also get to know that whatever neoadjuvant chemotherapy we have used, whether that chemotherapy the patient is responding to that or not. So this is the advantage of a neoadjuvant treatment. So there was a question asked, what are the advantages of a neoadjuvant treatment in the last the recently concluded NEET exam. So this was the advantage, which you can easily also see now that with a neoadjuvant, this is what. So what is RACIST? How, when the RACIST is applied, and how on the basis of RACIST the treatment is modified in a carcinoma breast is something important for us. Then another thing which we need to know in breast, this was about the response. Then the another thing which has come up in the prognosis. We know prognosis of a patient of carcinoma, for any malignancy for that matter, prognosis is the very important thing, right? And we know that there are various things. I'll show you that table. That table is very important for us. We talked about the prognosis in detail in our classes already, but what is new here, we have to know. There is a calculation of prognosis can also be done. We can assess the prognosis objectively by a calculation also. Now, what is that equation and what are the parameters in that equation, and how that calculation is able to assess the prognosis is something important. And that equation, first of all, is called Nottingham Prognostic Index. Now, what is this Nottingham Prognostic Index equation? It is 0.2 into size of the tumor plus the number of lymph nodes involved plus the grade of the tumor. So what are the parameters included in this equation? Size of the tumor, the number of lymph nodes involved, and the grade. You all very well know, those who have attended my classes, that we follow a Elston-Ellis modification of Bloom-Richardson grading system to grade breast malignant cells. So this equation is, first of all, is the equation which can also help us in assessing the prognosis of a patient of a carcinoma breast. Now in this equation, what value tells us the prognosis is also important. If the value we get is less than 2.4, it is said that the prognosis of the patient is excellent. If we get a value between 2.4 to 3.4, it is said that the prognosis of the patient is good. But if the value we get is 3.4 to 5.4, the prognosis is moderate. But if we get more than 5.4 value in this, the prognosis of the patient is poor. The prognosis of the patient is poor. So this is something what is important for us to know in the NPI. Now this table, which they have recently introduced in the latest edition of Bailey, is something very important for us. What are the various factors which are going to influence the prognosis? Size of the tumor, more is the size, the prognosis obviously will not be good. The higher is the stage, the prognosis. These are the adversely affecting the prognostic factor. There are disease related factors, there are patient related factors. So younger the age group, the worse will be the prognosis, because in a young age it is seen that the malignancies are very aggressive. So likewise, the patient who has a BRCA associated tumor, so if you can recall, in the recently concluded NEET, there was a question, which of the following is not a bad prognostic factor, or which of the following does not adversely affect the prognosis of a patient of carcinoma breast, where there was a BRCA associated cancer, there was Ki67 index high, there was ERPR positive. Answer was ERPR positive there. So this table, for that very reason, is a very important table for our exam. So please note this table. So this table is something which is important for us. Then coming on to another thing, the molecular classification of carcinoma breast. We have talked about this molecular classification in detail in our classes. This molecular classification, we know, is on the basis of gene expression. This molecular classification in carcinoma breast, we know, is on the basis of gene expression. What is recently incorporated in this is the Ki67 index also, and then Claudin low is added in this. So this is something latest in the molecular classification. So please note this molecular classification. We know the best prognosis is with a luminal A type, and it's a most common type, and basal type or a triple negative has a worst prognosis also. We know that. Now in this molecular classification, this addition of Ki67, which is the index of mitotic index, is added, and Claudin low type is another addition here. So this is something which we need to know about the prognosis part, then the molecular classification. Then another thing which is recently updated is the follow-up of a patient. There is a change in the follow-up advice of the patient who has received a complete treatment to of a carcinoma breast is now there. What is a follow-up advice? What is the latest update on a follow-up advice? The present guideline says once the treatment of a carcinoma breast got over, you should call this patient 3 monthly for first 2 years, 3 monthly for first 2 years for clinical examination. Once the 2 years got elapsed, call them 6 monthly for another 3 years for clinical examination, and once 5 years got elapsed, call them annually now. And whenever the patient is coming annually, also add a mammogram. So mammogram is going to be done annually, and this is the clinical examination follow-up advice to a patient of a carcinoma breast, which is recently updated here. Right now, then we already have talked about that in our classes. There is something called red flag sign. Any patient of carcinoma breast, if comes to us with those red flag signs, we are supposed to do a genetic evaluation of the patient and then the family. So this table is a very important, it's a very long table, but at least please, because this is something important, so please try to remember at least up to this. Try to remember, because they can frame a question which was last year they framed that a female with a family history of carcinoma breast at the age of 25 years comes to you, what will be your next step? So when to do a genetic evaluation of a particular patient to find out if whether there is a high risk family and a high risk patient is there or not, individual is there or not, this is on the basis of this table. So this table per se is very important. No need to remember the last one, but at least remember the first, which I have marked at least for our exam. So this is something further important for us. So this was the update which is there in a breast malignancy part, right? There are certain updates on the benign diseases also, but before I take that, let me ask you a question. Let me take your questions. So please let me know if there is any doubt here in what we have discussed, so that we can get on further. So MedSlam asks, the imaging in RECIST will be PET scan. See, we can use ultrasound, we can use MRI, and we can also include PET in the RECIST. So PET is a recent addition in the RECIST. So the response evaluation can be done by a PET also. So this can be done by clinical examination, this can be done by ultrasound, this can be done by MRI, this can be done by CT in a given malignancy also. But now PET is also incorporated to assess the response. So PET is there. So please, sir, inform about HIDA and Morgagni hernia. So we are not there. So whatever is the thing we have discussed, if there is a doubt, please let me know. Please let me know about it so that we can get on with the further discussion. Are we good to go, guys? Can we proceed? Okay, so let's proceed. Then comes this index. No need to go into the detail. Just remember, there is something called Lucknow-Cardiff breast nodularity scale. Females who have a ANDIs, aberration of normal development and involution, fibroadenosis, they commonly have a multiple lumps. So the multiple lumps the females who have, after ruling out that they have a malignancy in them, if it's a benign disorder, that is ANDI, their nodularity of the lump is graded into 5 categories. 0 is normal or non-nodular, 1 is minimal, 2 is mild, 3 is moderate, and 4 is severe. So what is 0? That is normal. What is minimal? This is 1, this is 2, this is the mild one, this is the moderate one, and this is a severe one. So what is the Lucknow-Cardiff breast nodularity scale? Is something which is recently incorporated in the latest edition, so is something important for us to know that. So this is a Lucknow-Cardiff index in which the nodularities have a ordinal scale shown in the image. So this image and this scale is something which is important for us to know. Then comes, now this is something I feel is important for a specific reason. This is about the treatment of a breast pain. Breast pain, we all know, is called mastalgia. Mastalgia is a breast pain, and this is a very common complaint which brings the female to the clinician in breast clinic. So mastalgia can be cyclic mastalgia. Mastalgia can be non-cyclic. What is non-cyclic and what is cyclic? We don't need to go into the detail of that though, but just few important points in that. Cyclic mastalgia means the mastalgia is happening with the cycles of the menstrual cycle. It is corresponding with the menstrual cycle. Non-cyclic is, it is not corresponding to the menstrual cycle. Now, how will we know that the mastalgia is corresponding to the menstrual cycle or it is not corresponding to the menstrual cycle? There is a pain chart which the patient is supposed to fill. This pain chart is prepared by the AIIMS faculty, and this pain chart has been is a part of the breast chapter. So since this pain chart is prepared by the AIIMS faculty, so I feel this is something which they can check also in our exam, that if there is a mastalgia, the patient is supposed to prepare fill that pain chart. We don't need to go into the detail of that pain chart actually. We just need to know this point, that in that we have to, the patient, once the pain chart is filled, we get to understand whether the patient has a cyclic mastalgia or a non-cyclic mastalgia, right? Now, before the patient is subjected to the pain chart and the evaluation through that, we have to do a triple assessment in any patient who comes to us with a breast complaint. We know that we have to exclude the malignancy part. We have already done a triple assessment. Patient only has a pain as a problem, and now we are trying to figure out whether it's a cyclic pain or it's a non-cyclic pain. For that, the patient is provided with a pain chart, and the patient will be filling that pain chart, and we get to understand that it's a cyclic or a non-cyclic thing. Right now, how are we going to manage that patient? So the first line of management in such patient is reassurance and adequate support to the breast. Now, if the patient pain, because this pain is not, if very severe, patient most of the time there is a dull aching type of pain, patient is more concerned because breast malignancy is quite common, so they get concerned about the malignancy part. So you have ruled that malignancy part and you have reassured that, and the pain is not very severe, they get settled with that too. But if they are not getting settled with that, what is the next line of management? This is a next line of management there. And then if the patient visual analog scale of pain is more than 3, the pain is quite quite I'll not say very severe, but it's a pain which is bothering the patient. So in the visual analog scale, it is taking us number 3 or more. So in such cases, we may need to add either of these drugs. So how we manage this pain and what are the options in the mestalgia is something which is important for us to know in this mestalgia part of the in the latest development, right? Then comes about this image. Now this image I have taken directly from the Bailey, and in this image we all already know that we are supposed to examine the breast with the flat of our fingers. There is a dial of a clock method and there is a vertical line method. We have talked about that. So this image is showing that this is the part of the hand which should be used for palpating the breast, and this is the dial of a clock method which is shown. So this can be an image based question in our exam which we should know about, right? So this is the another thing which we need to know here in the examination and the benign part of the breast. Then one more thing which I would like to add here on the update, because breast I feel is a very important topic per se, for a reason I told you that in mastitis, I'm not going to go into the detail of that, but there is something important which we have to know. See, a patient who has a mastitis may progress to develop a breast abscess. We know that. So now we also know at the same time the preferred treatment of a breast abscess is the aspiration, right? Percutaneous aspiration we prefer. So we prefer, instead of doing an incision and drainage of a breast abscess, we prefer doing a aspiration of the breast abscess. Multiple aspirations can be tried and the breastfeeding should not be stopped. But the further on this says, if by any chance, listen carefully, if by any chance the size of the abscess which you get to assess by ultrasound is more than 3 centimeter and the volume of the pus is more than 30 ml, if the abscess size is more than 3 centimeter and the volume of the pus there in that is 30 ml, we are supposed to put a suction drain. What is that suction drain? You all very well know that in MRM we used to put that closed suction vacuum assisted drainage system. So the same suction drain we put here. By putting that drain, patient will have that drain put, and with a negative pressure applied on the corrugation, when we press on that, the pus get evacuated, and with that drain we can also put a cold saline in that abscess to irrigate that abscess cavity, and that will also relieve the pain. So what is important for us is more than 3 centimeter or 30 ml more than pus, if it is there, we should preferably put a suction drain in such patient. That makes the things easier for female to carry on with the breastfeeding also. So this is something which we have to add on to what we already have the understanding of a breast. So let's quick recap on that. What we have talked about: volume replacement, volume displacement, short superior, short the long lateral, right? Then we also have talked about the RACES criteria, when to assess that RACES criteria, what are the RACES responses, and how the RACES response will decide the further modification in the treatment. Then we also talked about NPI, Nottingham Prognostic Index, and then we talked about the various prognostic thing which adversely affect the prognosis of a given patient, and then we also talked about a molecular classification of the breast malignancy which is based on gene expression. Then the follow-up advice we talked about a Lucknow Cardiff scale, we talked about mestalgia, and we also have talked about the recent advances in the breast abscess part. So this is something which is important for us to know in the updates on a breast. So if there is any doubt or any question, please let me know so that we can get on with the next topic. So are we okay? We can go ahead, right? So any new drug? Now one more thing, since in a pregnant female with a breast cancer, in first trimester, chemotherapy should not be given. In second and third trimester, chemotherapy can be given. Surgery can be done in any of these trimester. Surgery can be done in any of these trimester, right? And radiotherapy should not be given in any of the trimester. Remember, radiotherapy should not be given in any of the trimester, and we should not also be giving a monoclonal antibody, and we should not also be giving a tamoxifen or a hormone replacement therapy in a pregnant female, right? So this is we don't need to go into the detail of the management of a breast malignancy in pregnancy, but we should know that what all can be done in a what trimester, right? And in chemotherapy, we should not give 5-fluorouracil, anthracyclines, and taxanes can be given. They are considered to be safe, and sentinel node biopsy with low dose radioisotope, that is technetium-99 colloid sulfur, can be used in pregnancy also. So this is something which is important for us to know in breast. Now, any question? Sir, in breast cancer now, mammo can be done even in pregnant female also. Is this true? See, mammography can be done in a pregnant female. Mammography is as such, it's a radiation exposure. We should avoid doing a mammogram, but in a pregnant female, by shielding abdomen, we can do. This is not an update. This was always there, that mammography, if you're doing in a pregnant female, first of all, we should avoid doing a mammography in a pregnant female. But if you're doing a mammography in a pregnant female, you can do by shielding the abdomen. So mammography in a pregnant female should be avoided, but if you're doing a mammography, you should do it by shielding the abdomen. So this is what was always there, but then by and large, we avoid doing a mammography in a pregnant female, right? So this is something we need to know about a carcinoma breast update. Then comes, now coming on to the updates on the GIT. Some topics in GIT are very important, and one such topic is a functional disorders of the esophagus. Functional disorders of the esophagus. Now, Rinkita Malik is saying that the treatment of stage 4 malignancy. Treatment of stage 4 malignancy, Rinkita, I hope I am pronouncing the name right. In stage 4, in any advanced cancer, our primary objective of treatment is palliation of symptoms, right? If we can add to the quality of life, we always try doing that. So in a stage 4 malignancy of cancer breast, it is dependent on if it is hormone positive or if it is hormone negative, right? ERPR positive or ERPR negative. So if the patient is ERPR positive, we will offer a hormone therapy. We can add the CDK4 and 6 inhibitor in the form of palbociclib and the ribociclib also there. But if the patient is ERPR negative, and the patient has a visceral crisis happening, ERPR negative means patient or patient is refractory to hormone therapy, we then offer chemotherapy, because chemotherapy has its own side effects. So hormone receptor positive stage 4 breast cancer, we prefer giving a hormone therapy. We can add a CDK4 and 6 inhibitor with that. If the patient is hormone receptor negative, we give chemotherapy to such patients, right? And if there is a visceral crisis because of the distant metastasis is happening, in such cases, we give a chemotherapy. Surgery in a patient of stage 4 cancer breast, we don't offer. Surgery in stage 4 cancer breast is only offered when the surgery is adding to the quality of life. So when the surgery in stage 4 will add a quality of life, when there is a fungating, or ulcerative type of carcinoma breast is there. Whenever this kind of a breast malignancy is there, I'll just show you. If there is this kind of a breast cancer is there, patient, you can see, is actually suffering because of this. Patient is having such a growth. It's a growth which is hampering the patient's quality of life. So in fungating or ulcerative type of stage 4 cancer, we actually do a surgery. Otherwise, surgery also we don't offer in a stage 4 breast cancer per se, right? So this is something which we need to know. Any other question? Any other question, guys? Sir, we do IND if there are multiple cysts. No, in multiple cysts, we don't do IND. So, can we proceed? Are we good to go? Guys, quickly let me know. Okay, so let's proceed to the another very important topic for INICET purpose is a functional disorder. Now, in functional disorders of the esophagus, the confirmatory investigation we all know is now high resolution manometry. Now, earlier we were doing a conventional manometry. Now we do a high resolution manometry, and this is how a high resolution manometry graph looks like. Now, those who have attended my classes, we have talked about this high resolution manometry in our classes already. But what is the latest update on this? In this functional disorder of the esophagus, we talked about that too in our classes though. We follow a Chicago classification for classifying a functional disorder of the esophagus. This is based on a manometric classification. Manometric classification comes by the name of Chicago classification, which divides the various functional disorders of the esophagus. Now, what is important for us to note in this, the latest is, earlier we were following a Chicago 3.0, now we follow 4.0. Now we follow 4.0. Gurukul 4.0 is also coming. So Chicago also has come up with 4.0. So in Chicago 4.0, we don't need to go at our level in detail about it, but we need to know this per se. This 4.0 primarily divides the functional disorders of the esophagus into two categories. One is esophagogastric junctional obstruction disorder, esophagogastric junctional obstruction disorder, and the disorders of peristalsis. Disorders of peristalsis. Now, this is quite a complex thing, but then they commonly check on this. So let me try to make you understand in a simpler manner. See, you all very well know that this is a esophagus, and this is a lower esophageal sphincter. This is a lower esophageal sphincter, and the tone of the lower esophageal sphincter is always high. Now, in esophagus, there is a primary wave of peristalsis. When the esophageal phase of swallowing start, the primary wave of peristalsis goes down, and this takes the food bolus down, and the lower esophageal sphincter relaxes, and the food goes into the stomach. This is the normal physiology. Now, at our level, we don't need to go into the detail, but just remember, there is something called IRP. There is something called DCI. IRP is integrated relaxation pressure. We don't need to, as I said, go into the detail. Just remember, IRP is actually the term used for tone of a lower esophageal sphincter. This DCI is distal contractile integral. DCI is a distal contractile integral. As I said, no need to go into the detail. DCI is per se is the actually the whatever contractions are happening in the esophagus, which is taking the food bolus eventually into the stomach. It is the average of the amplitude, the pressure of those contractions. So distal contractile integral is the pressure of the contractile waves which are taking the food bolus to the stomach. Just remember this. Now, if by any chance, listen to this carefully, if by any chance in your given question it is said that the IRP of the patient is more than 15 mm of mercury, first of all, it suggests that the tone of the lower esophageal sphincter is high. Now, tone of the lower esophageal sphincter can be high. The tone of the lower esophageal sphincter can be high in eclasia cardia. Tone of the lower esophageal sphincter can also be high because of some stricture or malignancy infiltrating and making the sphincter fibrosed. So, if IRP told to us is more than 15, first of all, we get the information that this problem belongs to a esophagogastric junctional obstruction type of the functional disorder, right? Now, in this functional disorder, if IRP is more than 15, and along with that, if it is told that the patient has a failed peristalsis, there is no DCI, the peristaltic waves are not there, there is a failed peristalsis, it means the patient has a eclasia cardia, and this type of eclasia cardia is called type 1 eclasia. They have asked this question about type 1, type 2, type 3 eclasia in our exams already. So AIMS examiner commonly checks on the eclasia cardia part. So it is a type 1 eclasia, right? Then if by any chance we are told IRP is more than 15 mm of mercury and there is a pan-esophageal pressurization. There is a pan-esophageal pressurization is there. This means it's a type 2 eclasia. It is a type 2 type of eclasia. And if by any chance we are told that IRP is more than 15 and there is a premature contractions are happening or spastic contractions are happening in the esophagus, it is type 3 eclasia. And this type 3 eclasia is also called vigorous eclasia or spastic eclasia. Just remember this. Now, if by any chance IRP is more than 15 and there is a normal peristaltic waves are there, it means it's a structural problem leading to the lower esophageal sphincter narrowing. Structural problem leading to lower esophageal sphincter narrowing. It can be stricture, it can be malignancy infiltrating and leading to that. So how we make out about eclasia cardia in a given scenario, we probably have understood. Now in peristaltic disorders, for us, we just need to know diffuse esophageal spas and we just need to know nutcracker esophagus. There are other peristaltic disorders also, but at our level, we don't need to go into those details. So nutcracker esophagus is also called a jackhammer esophagus, first of all. Now, in this diffuse esophageal spas, IRP of the patient will be less than 15 mm of mercury, means IRP is normal. But here, there will be a premature contractions. There will be a premature contractions are there. Premature contractions are there. There is a number of premature contractions not needed at your level. If there are multi-peak, it is mentioned in your given question stem. There are multi-peak, intermittent, premature contractions are there having a amplitude between 450 to 8000 mmHg second centimeter. It is a diffuse esophageal spas. But if by any chance it is told IRP is less than 15 and there is a premature contractions but having a DCI, this is the DCI of more than 8000 mmHg second centimeter, it is a jackhammer esophagus or a nutcracker esophagus. So how are we going to differentiate disorders of peristalsis and the lower esophageal tone raised disorders? Through IRP. So first we have to see IRP and then we have to decide on the thing. If the IRP is normal and there is a premature contraction having a amplitude of 450 to 800, it is diffuse esophageal spas. If it is more than 8000, it is nutcracker. And if it is DCI, if IRP is more than 15 and there are failed peristalsis, no DCI, pan-esophageal pressurization mentioned, no need to go into the details. They will say that there is a pan-esophageal pressurization and there is a premature contraction, it will be considered as a type 3. Premature contractions are here also, but IRP will be less than 15. IRP more than 15 with premature contraction, it is type 3 eclasia. So this is something we have to know how to categorize type 1, type 2 and type 3 eclasia. Now, the basic part of the eclasia you all very well know that there is a bird beak appearance, there is a sigmoid esophagus, there can be sometime rat tail, but more common is a bird beak appearance. In chest x-ray there is a absent fundal gas with air fluid level. These are the basic things which I am presuming that you know. So we are talking about the updates. Now coming on to the management part. Coming on to the management part of a patient of eclasia which has a update in it. Now in management we very well know that we have an option of botulinum toxin injection treatment. We have an option of medical therapy in the form of calcium channel blockers and nitrates. we have the option of surgery, which is laparoscopic Heller's myotomy, which we now preferably do as modified Heller's myotomy, which is also called a Heller door operation. And we also have an option of pneumatic dilatation. And what is important, we have talked about in our classes though, we also have an option of POEM, per oral endoscopic myotomy. Right. Now, what is important for us to note, which is there in the latest, is we already know that the botulinum toxin injection treatment has the maximum chances of recurrence. The problem recurs as the effect of the botulinum toxin goes away. Calcium channel blockers are not very effective. The medical therapy for eclasia cardia is not very effective. Laparoscopic Heller's myotomy, what is important for us is it's a myotomy, we divide the muscle. What is the extent of myotomy is important. 6 centimeter proximal extent is there in esophagus. You divide the muscle 6 centimeter and you go into the stomach. 2 to 3 centimeter part of the myotomy should go to the stomach side, that is distally also. So this is the extent of myotomy we do. Now, since we are dividing the muscle, there are always chances of reflux. So now they say we should add a anti-reflux surgery. Either in the form of DOR, the anterior type of fundoplication, or TOPPET, that is a posterior type of fundoplication. In that we commonly add DOR. It's an anterior type of fundoplication. It's a posterior type of fundoplication. But what is important for us, which can be a potential question, in this anti-reflux surgery, we should never add a Nissen's type of fundoplication. Because that will lead to further the same problem, that is constriction of the lower esophageal sphincter, which we don't want. So we do a either anterior or posterior type of fundoplication, and in that it is a DOR type of fundoplication. Now, pneumatic dilatation, what is important for us? Pneumatic dilatation, we start with a 30 mm the diameter, the balloon, and we can go up to 40 mm. The problem with pneumatic dilatation is the perforation. So what we understood that laparoscopic Heller's myotomy need to have a anti-reflux surgery added. This can be taken as a problem, and then it's a surgery also. Then surgery has its own the issues. A patient may not be in a receptive stage to take a surgery as an option. So if we can do something minimally invasive, then it is better. So pneumatic dilatation is one such minimally invasive thing where the risk of perforation is there, but then the risk of perforation is very less if we do with a 30 mm type of a pneumatic dilator, right? POEM, the advantage of POEM, this image is important for us. This is how we do the POEM. We make a mucosal tunnel and then we enter into the submucosal plane and divide the circular and a longitudinal muscle in the given patient. So this is POEM, peroral endoscopic myotomy. The problem with peroral endoscopic myotomy, we are not adding an anti-reflux surgery. So there is a issue of reflux there. So these are the things which we have to know in the various treatment options which we have it for a eclasia cardia. Now, how are we going to answer a question in exam, and what are the latest things on that? The latest guideline on the management of eclasia cardia say in general, if you are asked what is the treatment of choice for eclasia cardia, in general, if the treatment of choice for eclasia cardia asked, the answer remains laparoscopic modified Heller's myotomy. But if by any chance they specifically ask you a question about a type of eclasia, the present guideline says if it is a type 1 or type 2 eclasia, if the age of the patient is less than 45 years, one should prefer doing a laparoscopic modified Heller's myotomy. But if the age of the patient is more than 45 years, we should first try a pneumatic dilatation. And if the pneumatic dilatation is successful, the first we try with the 30 mm, and if the patient has a successful, the symptoms got improved, we should repeat this pneumatic dilatation. But if this fails to relieve the patient symptom, we will offer a laparoscopic modified Heller's myotomy. Now, what is important? It is said in the latest edition, pneumatic dilatation works well if it's a type 2 type of achalasia, but it can also be offered in a type 1. Now, if it's a type 3 achalasia, if it is a type 3 achalasia asked in your question, then in that case, the answer to that question will be extended proximal. We have to extend the myotomy here, extended proximal Heller's myotomy. We have to extend the myotomy incision in such patients higher up. So either we offer this or we offer POEM. They say POEM works better because we can extend the myotomy without adding to the complication of the surgery with a lesser invasive procedure. So POEM works very well for a type 3 type of achalasia. But in general, commonly because POEM is not widely available, so at present we are doing this type of surgery only. So in general, let's conclude and do the recap of this so that there is no confusion left here. First of all, in achalasia cardia, what are the manometric findings we have to know. Now, once we diagnosed achalasia, if you are asked what is a treatment of choice in general about achalasia, the answer remains a laparoscopic modified Heller's myotomy where anti-reflex surgery is added, right? Pneumatic dilatation and POEM are the two other procedures which have a equal efficacy to laparoscopic modified Heller's myotomy though, but there are certain issues with them. So if there is a type 1 or type 2 achalasia asked and you are asked what is a next line of management in a less than 45-year-old patient, answer will be laparoscopic modified Heller's myotomy. But if the patient is more than 45 years of age, we first try doing a pneumatic dilatation there, and if it is successful, we can do a repeat of that. But if that fails, we go back to laparoscopic modified Heller's myotomy, and I told you this pneumatic dilatation works better if the patient has a type 2 type of achalasia, but it can also be offered to type 1. Type 3, we don't prefer doing a pneumatic dilatation. In type 3, we have to do extended myotomy. So either we can do it by a surgery or we can do it by POEM. The problem with POEM is that there will be a chances of a reflux. Patient will need to take the proton pump inhibitors for quite long, maybe mostly for lifelong, right? So the acid suppression has to be done. But extended proximal Heller's myotomy has an advantage. We can add the anti-reflux surgery. So POEM works well for type 3, but at present, commonly we offer extended proximal Heller's myotomy. Now, when are we going to offer a botulinum toxin? The botulinum toxin injection treatment in achalasia cardia will only be offered when the patient is not a candidate for any intervention kind of a procedure. Patient is not the patient is a high risk for any kind of intervention. Patient condition is such that you cannot offer any kind of interventional procedure. The patient condition is not allowing to go ahead with the intervention. Then only we offer a botulinum toxin, and it has a problem of a recurrence there. And then there is one more treatment option there, which is esophagectomy. Esophagectomy is one of the treatment option. So you should know what are the treatment option in achalasia. The esophagectomy is a treatment option in achalasia if there is a sigmoid or long-standing achalasia cardia is there. Long-standing, selected cases of long-standing, or when there is a S-shaped or sigmoid esophagus is there. So these are the points which are recently added in the latest edition, and in our classes, those who have attended, we have already done that thing which is now incorporated in Bailey. So this is something which we have to know about a achalasia cardia treatment algorithm per se. Now, if you look at it carefully, I have told pneumatic dilatation if is successful. Pneumatic dilatation, if is successful, we can go for repeat. So how will I know that my treatment option is having a success or a failure, that is assessed by this score. That is assessed by this score called ICART score. So what can be asked in our exam? What this ICART score is for? One question. Second, they can ask, don't try to remember the various things there in the ICART score, just remember the parameters. The second question which can come to us in our exam on ICART score, what are the parameters included in ICART score? The parameters included in ICART score are weight loss, dysphagia, retrosternal pain, and a regurgitation. Now what this ICART score for? This can be the another question, because this is something, another latest thing. This ICART score is for one, to know the severity of the disease. It can objectively define the severity of the eclasia cardia. Second, it can also help us to monitor the treatment outcome, whether the patient's symptoms are having a success in that, improvement is happening or not, or there is a failure. We get to know through this ICART score. So ICART score parameters and what this score is for is something important, and this image of poem is another important image for us. So this is something we need to know about a eclasia cardia. Now before I proceed, if there is any question, let me know, then only I'll proceed. I hope I am able to make you understand the thing. If not, I can go to any length to make you understand, but that your understanding of the latest thing, because these are all latest, you have to now get adapted to this latest part, because the recent advances are important in INICET. They commonly check those recent advances too. So are we in control, guys? Tell me. Good evening, Subhash. It's a total of 6 centimeter plus 3. No, 6 centimeter proximal, 2 to 3 centimeter distal. 2 to 3 centimeter. Component of ICART score are important, right? Yes, they are important. Okay. Then comes, we all know hematemesis. Hematemesis is very important for us, and I'm not going to go into the detail. In our one-shot revision also, I talked about hematemesis there too. Now, what is important for us in hematemesis? The latest addition which is done here, that is ROCAL score. This ROCAL score is something, a latest addition. Again, don't try to remember all the points in this, just try to remember the parameters. Parameters of ROCAL score are important. Age, shock, comorbidities, endoscopic, signs of bleeding, and diagnosis. These parameters are important for us, and what this ROCAL score is for, that is something important for us. ROCAL score is to predict outcome in a patient of a hematemesis, or which is also called risk stratification. ROCAL score is also to predict the risk of rebleeding. ROCAL score is also to predict the risk of rebleeding. ROCAL score is also to predict the risk of rebleeding. Now, let me take you and remind you, there is a Forest classification, which we already discussed in our classes. Forest classification is also to predict the risk of rebleeding. We have a Blatchford score. Blatchford score is there to predict the need of intervention. Predict the need of intervention in a given patient of a hematemesis. Now, in this ROCAL score, point to be highlighted, they can ask, out of the various scores available in hematemesis, which score has a endoscopic finding included in that. So it is a ROCAL score which has endoscopic findings included in that, right? So please remember, Forest is a classification which is an endoscopic classification of a bleeding. So score, we are talking about score. So score which has an endoscopic thing in this is the ROCAL score, right? Then this image is another very important image for our exam. We know that in any patient who has a hematemesis happening due to varices, there's a AIM 65 score also, Kruti. There's a AIM 65 score also there, but we usually don't use that. AIM 65 score also is to predict the outcome. AIM 65 score, you are correct, is also used to predict the outcome. Now, in patient who have a hematemesis, we can have a temporary bridge to control the bleeding by using a Sengstaken Blackmore tube. Now, what they can ask us in our exam, that they can give us an image and ask us about the which tube is there out of the 3 tubes which we use for control of a variceal bleeding for time being. We have a Linton tube, we have a Sengstaken tube, and we have a Minnesota tube. Now, commonly we use a Minnesota tube now, but then what is a catching difference between these 3 tubes? Just remember, in Linton's tube, which we don't usually use anymore though, has a single balloon. Sengstaken and a Minnesota tube both has 2 balloons, but the channels here, if you look, are in this. You see total number, if I count, actually it is 3, but total if I count 1, 2, 3 and 4. Here it is 1, 2 and 3. Just see the end. So if there are 3 channels, it is Sengstaken. If there are 4 channels, it is Minnesota. The additional 4th channel here is for esophageal suction, which we get the advantage with the Minnesota tube. And this Minnesota tube or a Sengstaken tube, the capacity of this gastric balloon which we inflated is 300 ml, and the pressure of the esophageal balloon, which they also can check, is 40 mmHg, and we can compress the esophagus for 12 hours. After that, we have to release that compression. So for how long we can have that compression, what is the pressure of the esophageal balloon, how to identify that tube is something important, and this is there in the latest Bailey too. So this is something which we have to know in that part. Then comes about a gallbladder. This is something which has a major update on in GIT further. Gallbladder as such, the biliary system is very, very important. It's a favorite topic of the AIIMS examiners. So let us try to know the important things on the gallbladder and the biliary system per se. We all very well know that acute cholecystitis. In acute cholecystitis, what are the presentations, how the patient of acute cholecystitis present? What is the investigation of choice for acute cholecystitis? We know it is ultrasound. So ultrasound is the investigation of choice for acute cholecystitis, we very well know, right? But now there is a criteria which has come up, which is a recent addition. This is a criteria called Tokyo Consensus Diagnostic Criteria for acute cholecystitis. Now, what is important for us? What are the local signs included in this? What are the systemic signs included in this? And what is the C imaging findings are there? And how we suspect a diagnosis and how we make a definitive diagnosis. So, what are the imaging findings? You all very well know. In ultrasound, if we get distended gallbladder, having a pericholecystic fluid, and having a wall thickness of more than 3 mm, it is acute cholecystitis. We very well know that. And if in addition there is a posterior acoustic shadow present, it is a acute calculous cholecystitis. So if there is C there, it makes one item of A, one item of B. With C there, it is a definitive diagnosis of acute cholecystitis is made. And in suspected diagnosis, the one item of 1A and one item of B, if there, it will make a suspicion of a diagnosis. So this Tokyo Consensus Diagnostic Criteria, first of all, is important for us. Then what is important for us here is, we know that there is a Tokyo classification, there is a Tokyo Consensus Criteria, there is a, now with the Tokyo Consensus Diagnostic Criteria, we diagnosed acute cholecystitis. With Tokyo classification, we divide cholecystitis into mild, grade 1, moderate, grade 2, and a severe cholecystitis. how to make a mild, how to make a moderate, how to make severe, we already have discussed and you probably know. Now, this is something which is very, very important and the latest in this management of a acute cholecystitis. Now, listen first of all carefully. Whenever you have a suspicion of a diagnosis of a acute cholecystitis, you all very well know the immediate next step, we keep the patient nilperorally, start IV fluid, we start IV broad spectrum antibiotic and anti-inflammatory drug. We all very well know that. This we all had a detailed discussion in our classes. So, if there is a mild cholecystitis, now what has come up in the latest? If there is a mild cholecystitis is there, on the basis of a Tokyo classification, if the patient is a low risk candidate for surgery, means the ASA you need to know through your anesthesia understanding, you know, if the ASA of the patient is 2 or less than 2, this is a low risk patient, we should go ahead with the early laparoscopic cholecystectomy. If the patient comes to us in 48 to 72 hours, now they say up to 7 days also we can go. So by and large 48 to 72 hours, but then the latest edition say we can go up to the 7 days also to do this early laparoscopic cholecystectomy. But if the patient is a high risk candidate for surgery, ASA of the patient is more than or equal to 3, the treatment which you have already started, this treatment will continue and most of the time this patient improves with that. So once they improve, we offer a delayed cholecystectomy to them after 6 weeks. So in a mild cholecystitis, more often than not, the patients are since in this category, more often than not, if the patients are in this category. So if a treatment of choice for mild cholecystitis is asked, the answer will be early laparoscopic cholecystectomy. Now, in a grade 2 cholecystitis, now moment you have a grade 2 cholecystitis patient comes, you have to first take a blood culture, which we have not taken in a grade 1, right? So we have to first take a blood culture and we start this in such patient after taking blood culture, and we started this. Now they say if the patient improves, this is the latest, if the patient improves and the ASA of the patient is less than or equal to 2, and there is an advanced laparoscopic facility available, advanced laparoscopic surgeon available, one should go ahead with urgent or early laparoscopic cholecystectomy in such patient. And if the patient improves but the ASA of the patient is more than or equal to 3, you should manage them with a conservative management and do a interval cholecystectomy after 6 weeks. And if the patient fails to improve with this treatment, we observe for 24 to 48 hours, we discussed in our classes. If the patient fails to improve, we offer a percutaneous cholecystostomy. Percutaneous cholecystostomy there. Now, if it's a grade 3 cholecystitis, again, you have to first send a blood for culture, and grade 3 means there is an organ failure. You know, grade 3, whenever there is an organ failure with symptoms of acute cholecystitis, it is grade 3. You again, after blood culture, you start that nilperorally IV fluid and all. Now, if by any chance, now this is something latest and important, if by any chance there is no negative factors, if there are no negative factors, what do you mean by no negative factors? If the total bilirubin of the patient is less than or equal to 2, there is no neurological failure, patient has no neurological dysfunction, there is no respiratory failure, and advanced center, the patient has come to you, it's a tertiary care center where the advanced laparoscopic facilities are available, we offer a early laparoscopic cholecystectomy in them. But if the patient has not in the advanced laparoscopic center or tertiary care center, we offer a percutaneous cholecystostomy. We offer a percutaneous cholecystostomy in them, and if there is a negative factors there, means the total bilirubin of the patient is either more than 2, or there is a neurological dysfunction provided in the question, or if there is a respiratory failure. So in such cases, we offer a percutaneous cholecystostomy, and after percutaneous cholecystostomy, if the general condition of the patient, the performance status of the patient is good, they will be offered an interval cholecystectomy after 6 weeks. But if the general condition, performance status of the patient is poor, we are done with just percutaneous cholecystostomy. So let me recap it so that you don't get confused in this. Most of the time, most of the time, if you are asked what is the treatment of choice for acute cholecystitis, in all probabilities, you will be checked on a mild cholecystitis treatment. Okay. And mild cholecystitis, the treatment of choice is early laparoscopic cholecystectomy, remember, right? Until unless we are told that the ASA grade of the patient is more than or equal to 3, where we offer them a conservative management, and later on we offer a interval cholecystectomy. Right? So if no information about the profile of the patient is there and the symptoms of acute cholecystitis provided, we will take it as a mild cholecystitis, right? If this specifically asks us about a grade 2, that is moderate cholecystitis. In moderate cholecystitis or in severe cholecystitis, both, first we have to take a blood culture, right? And then we start the NPO and the IV fluid and all that. And in this scenario, after starting a conservative treatment, if the patient shows signs of improvement and you have a patient who has a ASA of less than or equal to 2, you can go ahead with the early laparoscopic cholecystectomy as per the latest. But if the patient shows improvement but the patient ASA is more than or equal to 3, we continue with this conservative treatment, and later on we offer, after 6 weeks, a delayed laparoscopic cholecystectomy, which is also called interval laparoscopic cholecystectomy. Now, if by any chance this patient fails to improve, we have to offer a percutaneous cholecystostomy. Now, in a grade 3 cholecystitis, we have to first send for blood for culture, and in all probabilities, most of the time, just remember that way, it will be simpler for you. Most of the time, we actually offer a percutaneous cholecystostomy to them. But there are certain subset of patients who have a grade 3 cholecystitis, but they have a no negative predictive factor, and their organ failure is also good organs which are failed. So we don't need to go into that detail. We just need to know no negative predictive factors are there. What are no negative predictive factors? Total bilirubin of the patient provided is less than or equal to 2. There is no neurological dysfunction. There is no respiratory failure. So if this is not there and the patient is in an advanced tertiary care center provided, we will go ahead with the early laparoscopic cholecystectomy. And if the patient is not in an advanced laparoscopic center which has to be provided, then we will do a percutaneous cholecystostomy in this scenario also. And if there are negative predictive factors are there, we offer a percutaneous cholecystostomy per se in a grade 3 cholecystitis. So again, summarize. Grade 1, early laparoscopic cholecystectomy until unless there is a patient who has having a ASA more than or equal to 3. Grade 2 cholecystitis, first send blood culture and see the response to the conservative treatment. If the patient is responding and the ASA of the patient is good, that is less than or equal to 2, we can go ahead, and the patient is in advanced laparoscopic center, we can do a early laparoscopic cholecystectomy, which has to be provided. If the ASA of the patient is more than or equal to 3 and the patient is improves on the conservative treatment, we will continue with this conservative treatment and offer a delayed laparoscopic cholecystectomy. If the patient is not in an advanced laparoscopic center. Now, if the patient fails to improve, we offer a percutaneous cholecystostomy to that patient. So improves, advanced center provided, then an ASA less than or equal to 2, early. Improves, but the ASA is more than or equal to 3, we offer a delayed laparoscopic cholecystectomy in them. But if the patient fails to improve, we offer a percutaneous cholecystostomy. So, and in grade 3, we have already understood. So this is something which is a latest addition, and this is a big flow chart there in the Bailey. So this becomes important for us. Now, another very important thing. Now, if the patient is planned for a laparoscopic cholecystectomy, this is something very important. Now, in laparoscopic cholecystectomy, you all very well know, in gallbladder, there are good number of updates there. In a laparoscopic cholecystectomy, you very well know that there is a higher chances of a CBD injury in comparison to open, right? So, there is a concept of safe cholecystectomy has come up, which was always there, but then it has now been incorporated in the latest edition of Bailey. Right? Now, what is this safe cholecystectomy? Before we proceed to that, because laparoscopic cholecystectomy is a basic laparoscopic procedure, and as an undergraduate, laparoscopic cholecystectomy also very commonly asked as an operative procedure in your spottings and in your operative vivas also. So what is a pre-anesthesia workup required in a patient of, what is a pre-anesthesia workup required in a patient of a cholecystectomy? This table is important because in INICET they can ask you that which of the following test is not required in a patient who is planned for a laparoscopic cholecystectomy, because there is a separate thing in the latest Bailey, right? So this is something, these are the tests done before the patient planned for a cholecystectomy. Now in this safe cholecystectomy, what all we need to know? In this safe cholecystectomy, what are the important points for us? There are many things which are asked in this, but there are certain important points for us to know here. We have to know how to predict difficult cholecystectomy. How to predict difficult cholecystectomy, one, we have to know. Second, we have to know about something called B safe. Second, we have to know something called B safe. Third, we have to know there is something called R4U line, which I already talked about in my one-shot revision video also. And there is something called a critical view of safety, which we have to know. And then there is something called red flag signs in this. So all these are important. And then we have to know there is a bailout strategy in this safe cholecystectomy. Bailout strategy. And then there is a timeout rule in a safe cholecystectomy. These are the things we need to know in this discussion on a gallbladder. There is a question asked by Godavari. So we don't plan open cholecystectomy in any case. We can do open cholecystectomy, but now we prefer doing a laparoscopic cholecystectomy. It is not that we don't do, but we prefer doing a laparoscopy, right? Now, how to predict a difficult cholecystectomy? There can be a question in our exam asking you which of the following is not a predictor of a difficult cholecystectomy. So it's a long list, guys, but it's a very important list. I have no choice but to tell you this because AIIMS examiners, commonly the hepatobiliary system, you all know, is a very important and a favorite topic of the AIIMS examiners. Now, in this difficult cholecystectomy, the predictors: male gender, age of the patient if more than 65 years, late presentation of acute cholecystitis for more than 48 to 72 hours if the patient comes. Patient has previous multiple attacks if the patient has in past. If the patient is having a previous upper abdominal surgery, you can expect a difficult cholecystectomy. And if the patient has a cholecystostomy done in the past, and if the patient is obese, and if the patient has high ASA, these are the patient-related factors which are there to predict a difficult cholecystectomy. Now, there are imaging related factors and lab investigation related factors also. In imaging, we can do ultrasound, we can do MRCP. Commonly, we do ultrasound in gallbladder, but if by any chance MRCP done, that also can predict a difficult cholecystectomy. Ultrasound can also predict a difficult. So abnormal lab findings, abnormal LFTs, if somebody has, it predict a difficult cholecystectomy. In imaging findings, these are important further. In imaging findings, if the gallbladder wall thickness is more than 4 mm. If the gallbladder wall thickness mentioned is more than 4 mm, it's a predictor of a difficult cholecystectomy. If the gallbladder is told in the imaging is distended with an impacted stone at neck, if it is told that the patient has a contracted gallbladder, if the patient has Mirizi syndrome or cholecystoenteric fistula, or if the patient has gallbladder perforation or gangrenous gallbladder mentioned, it's a predictor of a difficult cholecystectomy. And if by any chance patient has cirrhosis, portal hypertension or extrahepatic biliary obstruction, if these are there in the imaging findings, any of these are there, it again predict a difficult cholecystectomy. Now intraoperatively also you can make out, once you put a laparoscope, you can also make out that it's a difficult gallbladder. What are the things? Shrunken gallbladder, patient having a liver edge retracted, or liver is fibrosed or cirrhotic. These are the factors which can predict a difficult cholecystectomy. So what are the predictors of difficult cholecystectomy? First of all, we have to know. Then we have to know about this be safe. Now we just don't need to know what is this be safe stands for, but we have to understand the be safe also. This B stands for bile duct, B stands for a bile duct, S stands for a Rouviers sulcus, A stands for hepatic artery, F stands for umbilical fissure, and E stands for enteric, which usually stands for duodenum. It can apply to colon also. Now listen to this, what this be safe actually is for. The moment we insert a telescope, the safe cholecystectomy protocol says, first get yourself anatomically oriented to these be safe structures. First get yourself oriented to these be safe structures. So what are the be safe structures? These be safe structures orient the surgeon about the anatomy around the gallbladder, right? Now once you got oriented to this be safe structure, the further guideline says that now you are supposed to proceed to your dissection in achieving a critical view of safety. Now, how are you going to proceed to your dissection to achieve a critical view of safety, and what is this critical view of safety? First of all, once you got yourself oriented to the be safe anatomy, it says draw a imaginary line called R for U line. Draw a imaginary horizontal line called R for U line. What this R for U stand for? This R for U line stand for Rouviers sulcus, line joining Rouviers sulcus, base of a segment 4 and a umbilical fissure. Draw a line joining Rouviers sulcus, base of segment 4 and umbilical fissure. Now see this. This is the Rouviers sulcus. This is the base of the segment 4 and this is the umbilical fissure. So this line is drawn, which is called R for U line. The guideline says if you want to do a safe cholecystectomy, you have to stay above this line. This is my safe zone and you have to not go below this. Now once you have done the R for U line demarcation, now what you have to do, you have to bear a Calotte angle. You have to bear a Calotte angle. I'm not going to go into the detail of the working Calotte angle, the boundaries. What is working Calotte angle? Please understand, there is a working Kellogg's triangle, the boundaries you all know. This working Kellogg's triangle has cystic artery and cystic duct in it, and there is a anterior and a posterior peritoneal fold sandwiching this Kellogg's triangle, which is covering this Kellogg's triangle. So first of all, this is a working Kellogg's triangle here. Now I have to bear this Kellogg's triangle staying above the R4U line. Now once I bear this, I remove anterior and a posterior peritoneal fold, I should get this view. This is a very, very important to do a safe cholecystectomy if I want to avoid a CBD injury and the other complications in this cholecystectomy. I have to achieve this critical view of safety. So what is this critical view of safety? The critical view of safety says that after denuding the anterior and posterior peritoneal fold around the working Kellogg's triangle, you should only be seeing two tubular structures going towards the free edge of lesser omentum. If there are more than two tubular structures going towards the free edge of lesser omentum, your critical view of safety has not achieved. More dissection is needed. And to get this critical view of safety, you have to go at least, this is important further for us, 2 centimeter away from the free edge of lesser omentum and bear this cystic plate. Bear this cystic plate. So what is this critical view of safety? The critical view of safety is there should only be two tubular structures going toward the free edge of lesser omentum. If you get those two tubular structures going toward the free edge of lesser omentum, then you are safe to divide those two tubular structures, because then the two tubular structures are going to be cystic artery and cystic duct. But if there are more than two tubular structures, it means you still need a further dissection. So achieving a critical view of safety is very, very important for us. So what is this critical view of safety? I hope we have understood. So we have understood be safe, we have understood R4U line, we have understood critical view of safety. Now what is this red flag sign? Red flag sign is if I get a anatomical disorientation while I put a telescope, I am not getting a anatomical orientation of the B-safe structure. If I am getting a anatomical disorientation, I am not clear about the anatomy, the B-safe there, I'll not be able to make out R4U line. Second, if I am not able to timely progress, in my dissection. What does that mean? Means I am at one place, I am getting stuck and the dissection is not going further for quite some time. So timely progression of the dissection is to clear the anatomy is not happening. Third is when there is a visual difficulty in visualizing the operating field. Visualizing the operating field. How will the difficulty in visualizing the operating field happens? What happens is sometime when you do a dissection for quite some time and you're struggling, the gallbladder is difficult, the bleeding happens, and because of the bleeding, the light which is thrown through the light source get absorbed by the blood and there is a dark field develops. So there will be difficulty in visualization. So if any of these things are happening in your dissection, it's a red flag sign for you. So you should now immediately, once you are getting this kind of thing in your dissection, take a time out. What do you mean by this time out? Stop. Take a pause. Don't go further in your dissection. It's a difficult situation. So take a time out. Get yourself oriented to the B safe again. Try to get oriented to the B safe again. But if you can't get oriented to B safe again, you take a second opinion. You have another surgeon there in the OT. Take a second opinion from that. And because the another surgeon who is outside, he is quite relaxed in comparison to you because you are stressed at this moment, so he may give you a better idea of the anatomy. So don't hesitate in taking a second opinion. Now even after taking a second opinion, now this is important, even after taking a second opinion, you could not achieve a critical view of safety and you are having an anatomical disorientation or there is a difficulty in visualizing the operating field is happening. You are now supposed to bail yourself out. Now you are supposed to bail yourself out, that you have to get out of this without causing a complication to the patient, so that there's a safe cholecystectomy accomplished. So what are the bailout options in such scenarios? You could not achieve a critical view of safety, and now the second opinion also you have taken and you're not able to get yourself oriented and there are red flag signs are existing. Now try to do a bailout thing now. What are the bailout options? This can be a potential question to us. What are the bailout options for us? There are 5 bailout options. One option is abort the procedure. There is no harm aborting the procedure. Abort the procedure because giving a complication to the patient is not something you should be doing it just because you have proceeded with the procedure. Second option is convert this procedure to open. Convert it to open. You have second option as convert it to open. Third option is do a fundus first approach now. Try doing a fundus first approach. Now, what is this fundus first approach? This is a gallbladder, you know, and I have started my dissection from here. I am going towards the fundus. In a conventional, I start from the working callots and go towards the fundus. Now, that is not happening and giving me the critical view of safety. So, I have to now go from fundus to the working callots triangle. So, that is called fundus first approach. That is another bailout strategy we have. The fourth bailout strategy we have is do a subtotal cholecystectomy. Do a subtotal cholecystectomy. What is this subtotal cholecystectomy? Just remove this gallbladder, open this gallbladder and remove all the stones, and the gallbladder which is critical view of safety is not achieved and the gallbladder is having a difficulty in achieving that and there is adhesions there. Just close the gallbladder from there where there was an adhesion and do a subtotal cholecystectomy. That is a safer idea. Then fifth option is do a cholecystostomy. Cholecystostomy. So these are the bailout options. So what we have understood, let's summarize it. Again, do a recap. 1. You have to first know what are the difficult predictors of a cholecystectomy. What are the predictors of a difficult cholecystectomy? Sorry. Second, you have to know what is B safe and what this B safe is for. Then you have to know what is R4U line and how R4U line guides you to do a safe cholecystectomy. That is, you have to stay above it. Then you have to know that what is a critical view of safety. Then you have to know what is a timeout, when to take a timeout when there is a red flag sign. What are the various red flag signs? And then we have to also know what are the bailout strategic options. So they can frame a question saying that the surgeon is having a difficulty in making a critical view of safety, and the second surgeon opinion also has taken. Now, which of the following is not an option to the surgeon? So what are the bailout options? We have to know. So these are the things which are there in the latest edition, and there's an elaborate discussion on that. So that makes it very important for us to know on this. So this is something we have to know here. So then comes, so this was about a discussion on the safe cholecystectomy. And then another topic which is very, very important for us in INICET per se is about the sepsis. Sepsis is another very important topic for us. I hope, guys, all of us in control. Any question there before I proceed? I have included all these updates in my Gurukul app already, guys. Don't worry about it. All the updates, these are the hand-picked updates which I think are very important. I have included in our discussion for INICET. So are we good to go, guys? Can we proceed? Can we proceed? Are you understanding? Please let me know. Rovier sulcus is a sulcus where the sectoral ducts of there is a division of the liver. So the sectoral duct or the portal vein tributaries are running, and there is a white line kind of a demarcation happens on the liver surface. That is called a Rovier sulcus. In gallbladder cancer, both mass and jaundice are late features. ये कहाँ से आ गया? Yes, these are the late features. These are the late features. The jaundice in a carcinoma gallbladder is a late feature, and the mass, clinically appreciable patient coming to you with a mass, is a late feature, right? So then comes about the sepsis part. Now in sepsis, there is another update which is there. First of all, you all very well know, because sepsis is a very important topic further, we follow sepsis 3 guidelines. Now we follow sepsis 3 guidelines to classify a patient in having a sepsis. In this sepsis 3 guidelines, you all very well know, SIRS is not a part of sepsis criteria. SIRS is no more a part of sepsis criteria. Then sepsis is defined by a SOFA score. We all very well know, more than or equal to 2. And severe sepsis term is no more existing in the latest. We have a septic shock, which is defined as this. This table is important for us. So septic shock is defined like this. Severe sepsis term is no more applicable. Sepsis is defined by SOFA score of more than or equal to 2. SIRS is not a part of sepsis criteria, right? Any patient who has a microorganism invasion in the body develops SIRS. What are the features of SIRS? We know, but it is no more a criteria to define sepsis. This is something important. Severe sepsis term is no more there as per the sepsis 3 guideline. What we need to know for us for our exam is sepsis. We all very well know that is a very common cause of morbidity and mortality. Patient who have a sepsis or develop a septic shock, very high mortality are there. So there are various studies were going on to decrease the mortality due to septic shock. Now, after multiple studies, there is a cumulative data was taken from those multiple studies, and that data is summarized that into one guideline, which says if we follow that way, after multiple studies, a guideline has come up which is called a surviving sepsis campaign guideline, which is called surviving sepsis campaign guideline. Now, this surviving sepsis campaign guideline says, after the cumulative data has come from various studies, that if we follow this way of patient management of a septic and septic shock, the chances of decreasing a mortality of such patients are very high. So what this surviving sepsis campaign guideline says is something which is included in the latest edition. First of all, in surviving sepsis campaign guideline, it says that whenever you are suspecting any patient who has sepsis or having a septic shock, any patient who comes to you with a suspected sepsis and a septic shock, one should always strive to achieve certain goals. So what are the goals one should strive to achieve here? And once this guideline says, if you strive to achieve these goals in a timed framed manner, the mortality due to sepsis and septic shock get majorly curtailed. So what are the goals to be achieved in this, and what timed framed approach which this sepsis surviving sepsis campaign guideline says, we have to know. It says we should, in any patient who has a suspected sepsis or septic shock, we should strive to get a CVP of these patients at any time between 8 to 12 mm of mercury. We should strive to achieve their mean arterial pressure at any time more than 65 mm of mercury. And we should always strive to achieve their mixed venous oxygen saturation at any given time to more than 70%. And we should also strive to achieve in them a urine output of more than 0.5 ml per kg per hour. So if we strive to achieve this in a aggressive timed framed manner, we have the maximum chances of saving a life. So what are the goals to be achieved mentioned in a surviving sepsis guideline? First of all, we have to know. Now, what is this timed framed manner? This surviving sepsis campaign guideline says that aggressively, the moment a patient who has a suspected sepsis or septic shock comes to you, you have to aggressively give them 3, give 3 and take 3 from them in a timed frame manner. First of all, we have to know what is to be given in 3, what is to be taken in 3, and what is this timed frame thing in that. it says immediately given to them, there are three things you have to give them in a time trained manner. IV fluid challenge, IV fluid challenge of crystalloid of more than 30 ml per kg body weight. You have to give them IV antibiotics after obtaining a blood culture. How the time frame manner thing happens, I'll let you know. And you should also give them oxygen and monitor their urine output. These are the three things we have to give them immediately. There are three things we have to take from them also immediately. What are the three things? Take blood to assess their lactate level. Take their blood to assess a full blood count. And take blood to assess the culture and sensitivity of that blood. So these are the give 3 and take 3 in that. And this 6 things which are supposed to be done here in a timed frame manner in this surviving sepsis campaign guidelines named as sepsis 6 bundle or resuscitation bundle. Sepsis 6 bundle or a resuscitation bundle, right? Or stop sepsis bundle, which is also called stop sepsis bundle, right? Now, what timed framed manner it says? It says there are certain tasks, the surviving sepsis campaign guidelines says there are certain tasks you have to complete in within 3 hours. There are certain tasks you have to complete within 6 hours. So the task to be completed in 3 hours are: 1. Measure lactate level. Second, start IV fluid challenge. Obtain their blood culture. And start IV antibiotic. Immediately you should do that. Now this says to be completed in 3 hours. Now what is important and what is further has said in that, all these things though to be completed in 3 hours, but it is better if we do it within 1 hour. As early as possible we do, better it will be. And we should also add oxygen if required to these patients. These are the things to be done immediately, but to be at least completed within 3 hours. There are certain tasks to be completed in 6 hours. What are the tasks to be completed in 6 hours? Now, after this IV fluid challenge of 30 ml per kg body weight, you have already given IV fluid challenge of 30 ml per kg body weight. If the patient still has a mean arterial pressure of less than 65 mm of mercury, we know that we have to always strive to achieve a mean arterial pressure of more than 65. So initial fluid challenge fails to raise the blood pressure. So no delay, add immediately vasopressors, and the preferred vasopressor is noradrenaline. And if after adding a vasopressor still there is a persistent hypotension is there, that is mean arterial pressure is still less than 65 mm of mercury, you should keep giving the fluid, and now you should take a measures to measure their central venous pressure so that you give fluid to keep the CVP around 8 to 12 mm of mercury. And you should also take measure their CVP and keep the CVP at 8 to 12 mm of mercury, and you should take measures to measure their central venous oxygen saturation. And if the central venous oxygen saturation is less than 70%, which we strive to achieve, we may need to add a PRBCs for them also, so that the central venous oxygen saturation improves, and remeasure their serum lactate level. So what are the tasks to be completed in 3 hours? Within 1 hour, then now they say it is better, and to be completed in 6 hours we need to know. So what is important for us? Let us do the recap. 1, in sepsis, the sepsis 3 guideline criteria is important, right? 1, Second, SIRS is out, severe sepsis, that is. Then surviving sepsis campaign guidelines. What are the goals in that mentioned to be achieved? Then what are the give 3 and take 3 in that, and what are the components of sepsis 6 bundle is important for us. Then what are the tasks to be completed in 3 hours and what are the tasks to be completed in 6 hours is something important in the latest update on this sepsis. Now, while all this is going on, the root foci of sepsis, whatever it is, you have to also take measure to get away from that root cause of sepsis also. Say for example, patient has a pyoperitoneum. You should not shy away from taking the pyoperitoneum, the pus away. If there is an abscess, drain that abscess, means take away the root cause of sepsis, which is the reason for this patient to go into sepsis and septic shock. So this is something which is the latest on a surviving sepsis campaign guideline. So any question now before I proceed to the next update on a general surgery in the refeeding syndrome? Quickly let me know, guys. Quickly let me know. Quickly let me know here. Can we go ahead, guys? So then comes the refeeding syndrome. Now this is another table which is important. Refeeding syndrome is another important topic which is again a favorite topic of the AIIMS examiner. Now whenever you start a parenteral nutrition, refeeding syndrome can happen in a enteral nutrition also, but refeeding syndrome is more common with a total parenteral nutrition. Now what are important for us in refeeding syndrome? What are the features there in a refeeding syndrome? What are the features there in any patient who has a TPN started develops as a component of a refeeding syndrome? The components of refeeding syndrome are hypophosphatemia, hypokalemia, hypomagnesemia, thiamine deficiency, and they can also develop hypocalcemia. Now, what is important for us in the latest update is this table. Who are the candidates who have a risk of developing a refeeding syndrome is there? Who have a risk of developing a refeeding syndrome is there. So this criteria, those who have a risk of developing a refeeding syndrome, is a potential question for our exam. So this table is per se is important for us, right? Now how to avoid a refeeding syndrome? We know that we have to gradually build the parenteral nutrition. We should not give the actual amount which we have calculated on a very first day. We should gradually step up the whole amount which we have calculated in a given patient to avoid a refeeding syndrome. So what is important for us in a refeeding syndrome? The features of refeeding syndrome, who is at a risk of developing refeeding syndrome, and then how to avoid a refeeding syndrome. So refeeding syndrome per se is another important topic for our exam per se for INICET. Then coming on to drains. Question on drains is very common in INICET exam, and this has become all the more important because there is a table which has been introduced in the latest edition of Bailey, where they have said we know that we should avoid putting drain as far as possible. So there are certain surgeries where we routinely place a drain. There are certain surgeries where we should not routinely be putting in a drain. So what are the non-GI surgeries where we should be putting and not putting a drain, and what are the various GI surgeries where we put in and we don't put in a drain? So avoid routine drain placement in a thyroid surgery, breast lumpectomy, and in inguinal hernia repair. Consider routine drain placement in these surgeries. Consider a routine drain placement in these surgeries. So this is an important table. In a GI surgeries, avoid drain placement in these surgeries and consider and selective use in certain surgeries. So this table per se is important for us to know in drain. Now, what are the various types of drain? Very commonly asked question. There is an open drain. There are closed drains. I'm not going to go into the detail. We have discussed that in our classes, those who have attended it. In open drains comes a corrugated drains, and corrugated drains, they drain the effluent with the help of the corrugation there, with the help of a gravity there, and this you commonly place in a abscesses. In closed drains, we have suction drains, which are also called active drains, and we have non-suction drains, which are called passive drains. Now, passive drain example, you can easily relate. The Riles tube, when you place and you connect it to a drain, it's a passive drainage system. By gravity and by the capillary action, the things are going to come out. And in suction drain, the another example of a passive drain is the abdominal drain, which we put in our abdominal surgery. That is also called Robinson's drain. Suction drain, we know the Jackson-Pratt drain and the Romovac drain, which we put it in after MRM, right? So those were the suction drains. So these are the things. Now, what is important further for us is in a suction drains per se, which can be a thing which we should know, because AIIMS examiner go in depth about the concept in various things, that in suction drains, whenever you are putting a drain near a vital structure, you should avoid putting in a suction drain, because when you put a drain near a major vessel or a important vital structure, because of the suction, the wall of the vessel or a GI organ can also get sucked in, and there can be a fistula formation in that. So we should avoid that in vital structures. Then this was about the drains, which you have to know. Then another thing which is important for us in INICET per se about renal stones. And since there is an update on the renal stones there, so we should know about that update too. Now in that renal stones update, you all let me, so that it becomes easier for you to understand that update. We very well know that we have an option of, for renal stones, extracorporeal shockwave lithotripsy for management. We have an option of percutaneous nephrolithotomy. You very well know that what are the indications of ESWL. You very well know what are the contraindications of ESWL. I'm not going to go into that detail. Just quickly, let me remind you, less than 2 centimeter size stone in a pelvis or in upper or a middle calyx, less than 1 centimeter stone in a upper ureter and a lower pole or lower calyx. Contraindications of are that you can't do it in a patient who has a morbid obesity, patient who has a bleeding disorder, orthopedic deformity, aortic aneurysm, the horseshoe kidney, the pelvic kidney, those were the contraindications. Now, what has come up in the latest, it was always there, but this surgery, which is now introduced as another modality of treatment for renal stone, which was always happening, but now has become a standard of care because it is now available in most of the tertiary care center, and that is called RIRS. At this moment, we are not going to go into the detail of what is RIRS, how this procedure happens. RIRS is retrograde intrarenal surgery. Earlier, what we knew, that whatever was the not an indication of ESWL, whatever is a contraindication of ESWL will be an indication of PCNL. Now what we have to know is RIRS, that is retrograde intrarenal surgery. Any patient, listen to this carefully, any patient who has a stone criteria, any patient, let's keep it simple, any patient having a stone criteria falling in an indication of ESWL, means the stone is less than 2 centimeter in the upper or middle calyx or in the renal pelvis or in the upper ureter or in the lower pole, but having a contraindications for ESWL. All those contraindications which we know are there. So if the patient has a contraindication for ESWL, now they say if the stone criteria is falling in a criteria of a ESWL, but there are contraindications of ESWL are there, in such stones, we offer retrograde intrarenal surgery. What is very glaring thing in this is, even in bleeding diastasis patients, which is a contraindication for ESWL, we know we can offer RIRS, right? So what we understood, where we'll offer RIRS as a treatment in a given stone disease patient, stone criteria meeting ESWL, but contraindication of ESWL are there. Now, when to offer PCNL now? The PCNL is offered when the stone either is more than 2 centimeter, or the stone is a staghorn calculus, or there is a failed stone cannot be removed by shockwave lithotripsy or RIRS, or lower pole calculi with anatomy which is unfavorable for shockwave lithotripsy. In such situations only now we offer PCNL. So now we commonly offer RIRS. In these selected scenarios, now we offer PCNLs. This is a latest update on a PCNL. Now the 1.5 centimeter is the thing, but up to 2 centimeter ESWL can manage. Up to 2 centimeter ESWL can manage. Who asked this? Bhupesh. So up to 2 centimeter ESWL can manage. It is 1.5 centimeter is a clear-cut indication, but up to 2 centimeter you can manage with ESWL. But if the patient has a contraindication for that and the stone is less than 2 centimeter, we should offer a RIRS. But if the stone is falling in this category, we offer PCNL. And what are the contraindication of PCNL? This is another thing which is now updated. These are the contraindication for PCNL. So what are the indications of RIRS? What are the contraindication for PCNL? And what are the now left out indication of PCNL is a latest update on the renal stones. So these are some of the updates which we are supposed to know. One more update before I get on with the few questions which I've selected from the previous year INICET, the handpicked questions. I tell you, that is about the burns. I should tell you about this in burns. Now, in burns, what is the latest update? In burns, what has come up is a new theory which has given by the latest edition of Bailey, says burns a two-depth burn theory. Two-depth burn theory. This two-depth burn theory divides the burn into two categories, group A and group B. Two-depth burn theory divides burn into two categories, group A and group B. Now, let's try to recollect what we had previously with us. We already knew that there is a superficial burn, first degree burn. We already know that there is a second degree partial thickness burn, and this superficial partial thickness burn is further divided into superficial partial thickness and deep partial thickness. Superficial partial thickness and deep partial thickness. Superficial partial thickness is one where there is involvement up to the papillary dermis is there. The deeper dermis involvement once happen, it comes in a deep partial thickness burn. And what are the features of superficial partial thickness burn? What are the features of superficial epidermal burn? We know that. And then there is a full thickness burn, we know, which is third degree and fourth degree. Third degree is subcutaneous tissue and fourth degree is the muscle and bone involvement. Now, in this deep partial thickness burn, what the latest edition of Bailey and Love says that deep partial thickness burns can be of further two types: mid-dermal deep partial thickness burn and a deep dermal burns. Now, mid-dermal and deep dermal. Now, if I have to make you recall the features of a deep partial thickness burn, you can easily able to recall that in deep partial thickness burns, the blisters may or may not be there. The patient will have a difficulty in differentiating sharp and a blunt pressure, right? Sensations will be decreased and there will be a difficulty in differentiating sharp and a blunt pressure, and the capillary filling will be absent. This is what it is, and it always heals with a scar. We knew that. Now, in this deep partial thickness burn, they say they have two categories, mid-dermal and a deep dermal. Now, we have to see this. Now, what they say, mid-dermal burns are the burns which have a sluggish capillary filling. It is slightly moist and having a sensation which are decreased but mostly intact. In mid-dermal burns, it has blisters. Again, I am coming back. It has blisters. It has sensation which are decreased but mostly are intact. Means it is the mid part of the dermis has involved in that, and it is slight oozy is there, means it is still moist. While a deep dermal burn is one having no blisters, it has capillary filling majorly reduced and or it is absent, and it will be dry. It will be dry and it will be blackish red in appearance too, right? It is dark red, it is blackish red, right? So this is a deep dermal, and full thickness we already know about. Sensations are completely lost and there will be a blackish and it will be completely dry. So this is something has come up. Now what is group A and what is group B? All those burns in this burn depth theory says all those burns which are going to heal with primary intention just by dressing and preventing the infection and the pain in them are called a group A burns. Group B burns are those which requires debridement, that is excision and grafting, which you remember, and a secondary intention closure. Secondary intention closure means having a cosmetic problem also, will having a functional difficulty also, because in such burns we will do the early excision and grafting part. So when you do early excision and grafting part, there will be a cosmetic problem and there can be a functional problem. In group A burns, they are usually going to get managed by just dressing and a primary intention, and they will have a functional and a cosmetic problem majorly not there. So these are the division of two depth burn theory into group A and group B. Now which burn comes in a group A, which burn comes in a group B? Now group A burns include superficial burn, superficial partial thickness, and a mid-dermal burn comes in a group A burn, because it usually get managed by a dressing alone, preventing infection so that they don't progress to group B, and a pain control. While a deep dermal and a full thickness burn comes in a group B burns. So what can be asked in our exam? What type of burns comes in group A, and what is a basic thing about a group A? Functional and a cosmetic problem is not going to be there. And what are the burns comes in group B, and what is a problem with them? They will require a secondary intention healing, and they will have a functional and a cosmetic problems, right? So now when a patient comes to us, this algorithm has come up in the latest edition of Bailey. Now, how we are going to assess that a patient has a group A burn and patient has a group B burn. Patient has a group A burn and which patient has a group B burn. So, moment a patient comes to us, it says, look at the burn and see if there is a epidermal integrity or Nikolsky sign. What is this epidermal integrity or Nikolsky sign? You apply a lateral pressure over the burnt area. If the epidermis is getting peeled off, it means the epidermal integrity is not there. So if the epidermal integrity is there, it is a superficial burn, that is first degree burn. Now if the epidermal integrity is not there, means the epidermis get peeled off, a Nikolsky sign is there. So if the epidermis get peeled off, now you have a gloved finger there, see whether the finger is getting slippery. Finger will slip only when the burn is moist. So all those burns which are moist will all come in a group A burn. So if the burn is moist, now see if it having a thick walled blisters and having these features, it will be a mid dermal burn, and if it's a thin walled blister and it is oozing majorly. It is oozing, very oozy and very painful. It is oozing and it is very painful and it is bright red and the sensations are all intact. It is a superficial partial thickness burn. And these burns will be a group A burns. These burns will be a group B burns. These burns will be group B. And in group B, if it is not slippery, means the burn is dry. Now, if it is red, having a no ooze coming and having a differentiation of the sharp and blunt pressure is difficult, it is a deep dermal burn. And if there is no sensation, complete anesthesia is there, it is absolutely white, it will be a full thickness burn. So how to make out a full thickness burn, deep dermal burn? There can be a question in exam on this because it has recently been incorporated. Now, what is further important for us? In group A burns, we manage them with a dressing. Now, what dressing is preferred now in them? They say we should prefer a biological dressing. What biological dressing we prefer? In biological dressing, we have two types of biological dressing, bio-brain dressing, and we have a amniotic cell membrane dressing. Out of this, preferred is bio-brain. But if it is not there in your choice, then we can also prefer hydrocolloid dressing. If that is also not there, then we can also prefer a paraffin gauze or a petroleum jelly soaked dressing. But if the patient has a group B burns, now this is further important. In group B burns, we should do early excision and grafting. In group B burns, we should do a early excision and grafting. So what is the management of group A? What is the management of group B? What are the burns comes in group A? What are the burns comes in group B? How to identify group A and group B burns? So this is something which has come up in the latest edition. And another latest update is, earlier it was said that we always start with the initial resuscitation with either a modified Parkland formula or a American Burn Association formula. We know that in a given question, it will be provided that from which formula the examiner is expecting you to calculate the amount of fluid required in a resuscitation. And in INICET, in AIMS, we follow American Burn Association formula, right? Now, earlier it was said that the colloid, the addition of colloid in a burn patient should be started after 24 hours. The latest update on the colloid administration says you should start colloid after 12 hours. The latest update says you should start colloids after 12 hours. So these are the certain important things in burns per se for us. Rest everything, the calculation of the percentage of body surface area, rest everything remains the same. Now, there is a question from ABC. Sorry for interruption by saying different topic. Please also discuss foreign body like butter battery and a stomach management. Okay. See, in a foreign body to the esophagus, if the foreign body gets stuck at a cricopharyngeal sphincter, listen, if the foreign body gets stuck at a cricopharyngeal sphincter, you have to take it out, right? If the foreign body negotiate a cricopharyngeal sphincter and comes in the stomach, and it is said that most likely that foreign body is going to pass off. But if this foreign body is a button battery, because it's an alkaline battery, so it may erode inside and it can lead to the erosion and the injury. So once there is a button battery, if it is there obviously if it is there up till the stomach, then only you can take it out. So you should take a button battery out. Otherwise, all other foreign bodies, once they have crossed the cricopharyngeal sphincter, you should not be taking them out. But if there's a cricopharyngeal sphincter, they get stuck, you should take them out. So this is the concept behind a button battery. So now, these are some of the very important updates which I feel we all should know before the INICET exam. All the other updates which are there, we have already uploaded in the app, so you can have a look. But then these updates, just focus on these updates at this moment and get on with the other revision part in your for INICET, and then get on with the other updates in the surgery there. So any question before I proceed to the questions? Can we proceed? So let's now see few important questions here. Now, one of the question is, I would expect your participation in this. Tell me the answer to this. Read the question carefully and tell me the answer. I expect participation from you guys. Corrosive injury, Nirmala Devi Bitra. Corrosive injury we have already covered in our discussion in the previous year questions. Last year the NEET questions I have discussed in detail about the corrosive injury. And please, one more thing, there is an update on trauma. How can you forget trauma for INICET? For any exam, trauma is important. Now what about the trauma updates? You should be asking me this. All those updates which are there in trauma, guys, I've already covered in our one-shot revision. So please, this is my sincere advice to you. Before INICET, once go through that one-shot revision very fast. If you have already done that, or if you are comfortable and you know the things, just, this is my sincere advice, just go through the trauma updates. The gentle one attempt of Foley's catheterization and that all those things about pneumothorax and all is something, please go through that. It will be very important for our INICET. So what is the answer? It's a patient who has a free gas under the dome of diaphragm. It's a pneumoperitoneum, which is also called a football sign. And in any patient who has a pneumoperitoneum, hollow visceral injury is there, hollow visceral perforation is there. So in any acute infective GI condition, we always start with resuscitation. And once the hollow viscera inside the abdomen perforates, we have to do the laparotomy. So the answer is going to be resuscitation and laparotomy without any confusion. Now answer this question. Answer this question. Quickly answer, guys. Again, a simple question. Whenever you find a swelling here and lifting the pinna, it is a parotid swelling considered until proved otherwise. And in a parotid swelling, the most of the time, it is a benign swelling until unless the features of a malignancy in the swelling are provided. In this given question, it is told that the patient has a pain and the swelling is near the angle and it is non-tender and firm for 3 months. If by any chance the same question I frame with the same swelling, having a swelling hard or having a lymph node enlarged in the neck or has a rapidly increased in size or having a neurological symptoms, means having a facial nerve involvement happening and the facial asymmetry is happening, our answer would change to, in the same question, to a malignant swelling. So clinical profile of the patient has a very important relevance to make a diagnosis in a given, and in AIIMS, please, in INICET, the exam pattern is quite set. Topics are by and large are same, but they go in depth in those topics. So please have your concepts right in those topics. Topics are more important than just the questions. Please focus on topics rather than just the questions, right? So answer here in this given question is pleomorphic adenoma. Answer in this given question is pleomorphic adenoma. Then coming on to this. Answer this question, guys. How to differentiate other swelling of parotid? Parotid can have either a benign tumor or a malignant tumor. There can be parotitis also, which is viral and which is commonly due to mumps. There will be a bilateral swelling in that case. Answer this question, guys. Again, a very commonly asked question, and probably you well aware of that classification. Very good. It is C2A. Why it is C2A? Because patient is asymptomatic. So let's quickly go back to CAP classification. C0 is no visible or palpable sign of varicose vein. C1 is telangiectasia or reticular vein. Telangiectasia term is used when the vein is less than 1 mm in size. 1 to 2.9 mm is reticular vein. C2 is varicose vein. Any vein more than 3 mm in size will be called as a varicose vein. C3 and asymptomatic will be written A, symptomatic will be written S. And C3 is edema. C4 is 4A, 4B and 4C. 4A is pigmentation or eczema. 4B is lipodermatosclerosis or atrophia blanche. C4C is corona, phlebectatica. C5 is healed venous ulcer. C6 is active venous ulcer. And C6R is recurrent active venous ulcer. So this is something very, very important. Now answer. This is a very commonly asked question. I have not seen any AIMS exam till date. Very rarely you will not get a question on this. So answer this. This is a very important scenario. We have discussed in that one-shot revision also. Answer, guys. A 25-year-old male patient presents to emergency with a history of RTA. On examination, the patient present with a subcutaneous emphysema and absence of air entry on the right side. Hypotension is there, vitals are unstable. Which of the following will be the immediate step of management? Answer. Very good. No investigation. You have to immediately do a needle thoracostomy. And where will you put a needle? Fifth intercostal space. And now the latest guideline says if the needle fails to relieve a pneumothorax, you should then proceed to finger thoracostomy. Because in some obese patient, the needle may not be able to get into the pleural space and you may not be able to get the relief of a tension pneumothorax in such situation. So we will do a finger thoracostomy. Fifth intercostal space in an adult, second intercostal space mid-clavicular line in a pediatric. But this is a initial thing. Subsequently, the needle is put in a second intercostal space mid-clavicular line in pediatric, fifth intercostal space mid-axillary line in adult. After this, we have to put a chest tube. Chest tube is going to put in the same intercostal space in both, that is fifth intercostal space in the mid-axillary line in a triangle of safety. So then answer this question. Again, a very commonly asked scenario. Sorry for this font size, guys. Just read the question. I'm sorry. I'll read the question for you. 34-year-old female after RTA was brought to the AIMS emergency with GCS3. She was intubated and sent for non-contra CT, which was found to be normal. What is the most likely diagnosis? Very simple question. Sir, is there any change of location of needle insertion in adult to second? No. No change. Godavari, no change. It's a simple question. Diffuse axonal, but listen carefully. Diffuse axonal injury is one head injury where the patient has a very severe head injury, yet the non-contra CT can be normal, but it is not always normal. It can be normal, but it is not always normal. in some of the patient of a diffuse axonal injury, one can have a blood in the basal ganglia or corpus callosum. There can be collapsed basal cisterns also with multiple contusions, multiple hemorrhagic contusions. So it is not always normal, remember, okay? And diffuse axonal injury, you all know, is the worst head injury. Then answer this question. Again, a very simple question. Sorry, again I have to read it. Undescended testis, diagnostic laparoscopy was done on right side blind ending testicular vessel seen. Next step, answer. Bhargav, yes, absolutely correct. Due to shearing tear between gray and white matter, absolutely right. Basal cistern damage, absolutely right, Godavari. Very good, Godavari. It is a patient who has an absent testis. So nothing to be done. And we all very well know the protocol of approach in a patient who has a non-palpable testis. In a undescended or a non-palpable testis, if a newborn has a non-palpable testis, we all know the approach consideration in that. In a non-palpable testis at birth, if a baby comes to you, your next step is do a clinical examination. If the testis is non-palpable, on clinical examination, you should reassure parents and tell them to come after 6 months. After 6 months, they come. Even if now they have a absent testis, they come with the same complaint. You again do a clinical examination, and if you find a testis in the inguinal canal, testis is palpable in the inguinal canal, you should do inguinal exploration. You should do inguinal exploration and do a orchiopexy of that. If the testis is still non-palpable, we should then in that case do a under GA examination. And in under GA examination, if the testis is palpable in the inguinal canal, do a inguinal exploration. If on under GA examination the testis is still non-palpable, the present guideline says do a laparoscopy. No need of doing ultrasound or MRI in these patients. You should, because anyways we have to do a orchiopexy, so go ahead with the laparoscopy. In a laparoscopy, if the testicular vessels are seen entering the inguinal canal, if the testicular vessels are seen entering the inguinal canal, you should do inguinal exploration and do orchiopexy of that. If the testis is found lying higher up in the above the deep ring, you have to do a staged orchiopexy in that. And if the testicular vessels are ending blindly, we will conclude that the testis is absent. So this is an approach to a patient who comes to us with an absent testis at birth. So answer this question now. Answer this question. Answer already there. Sorry. I should have erased it. So how good it will be in the exam, the answer is also there. You just have to, like, you get the SIM card the first time, you get the pin there. So few questions are such that there is a lucky draw kind of thing, that you erase that thing and you have the answer in that, and in some of the students don't have the answer in that. So you can check your luck also in that. So it is 1, 2, 3, 4. So primary survey. Now what is important for us to notice in primary survey, what all conditions are we supposed to manage? Airway obstruction we are supposed to manage in a primary survey itself. Tracheobronchial injury we are supposed to manage in a primary survey itself. Tension pneumothorax we are supposed to manage in a primary survey. Open pneumothorax we are supposed to manage in primary survey. Cardiac tamponade we are supposed to manage in primary survey. The cardiac tamponade, the things which have changed in the cardiac tamponade I have talked about in our one-shot revision also. We have massive hemothorax to be managed in primary survey and traumatic cardiac arrest to be managed in primary survey. Now, what is important for us to know further, earlier flail chest was included in that. Now, flail chest is not supposed to be managed in a primary survey. Logan says, late हो गया, late तो हो गया boss, but ये शायद फायदा कर दे. Component of Q SOFA. Now, which of the following is the components of Q SOFA? It's a multiple answers correct question. Or in other words, you can say except also. In Bhargava is asking, during airway intubation, we have to stabilize the cervical vertebra. Technically, it becomes first. I didn't get your question. So, answer is actually 2, 3, 4. We all know that. Any patient having a Q SOFA of more than or equal to 2 has a very high chances of having a longer stay in the hospital, has a very high chances of a mortality also. Heart rate is not included. Absolutely correct, Rinkita. Then answer this. It's a good question. Answer this question, guys. In this question, they expect you to, first of all, stage this cancer and then tell what are the investigations done in that staged breast cancer. Please tell me the stage of a breast cancer. Sir, if time problem, can we go with a general surgery breast trauma, sir? I didn't get your question. Answer is very good. Answer is 1, 3, 4. PET scan has no role in early breast cancer. What are the investigations done in early breast cancer? Complete blood count, chest X-ray, LFTs, bilateral mammogram you already have done in the triple assessment. You are supposed to do ultrasound of the axilla with a biopsy of the lymph node or FNA of the lymph node if the lymph node is found. Answer this question. It's a stage 2 cancer, absolutely correct. Who answered it? Kruti. Answer this question. It's again a very commonly asked question in INICET. It's a lightweight, large pore size mesh. We should use a lightweight, large pore size mesh, and you also need to know the European Hernia Society classification of groin hernias. In that, the most important thing for us is there is primary hernia, which is written as a pre as a prefix. There is a recurrent hernia, which is written as a R as a prefix. And indirect inguinal hernia, there is called a lateral hernia written as a L prefix. Direct inguinal hernia is written as M prefix, and femoral hernia, you have F as a prefix. Now, on the basis of the size of the defect, if the size of the defect is less than 1.5 centimeter, means admitting one finger, less than one finger, you'll use 1 for that. 1.5 to 3 centimeter, admitting 2 fingers, you'll use 2 for that. More than 3 centimeter, admitting more than 3 fingers, you'll use 3 for that. So, If it is mentioned PL1, it means it's a primary indirect inguinal hernia having admitting a finger less than 1 centimeter. Very good, Kruti. If large hernia, heavyweight, small pore. Very good. If a large hernia is there, very good. As per the latest, we use a heavyweight, small pore size mesh. Absolutely correct. Answer this now. Again, a commonly asked question, but we all must be aware of that. This Southampton score is very, very important for us, guys. Southampton is a classification of wound infection. 0 is normal healing wound. 1 is mild erythema. 2 is erythema with other signs of inflammation. 3 is clear or serohemorrhagic discharge if coming. 4 is pus discharge. 5 is severe deep infection. And then there is a asepsis score also, which is important for us. A stands for additional treatment. S stands for serous discharge. E stands for erythema. P stands for purulent discharge. S stands for separation of deep tissues. Separation of tissues. I stands for isolation of bacteria. And S stands for stay in hospital. This asepsis score and a Southampton classification is very important for actually any exam. Now, answer this. Chronic alcoholic patient comes to emergency with a pain epigastric region and a recurrent vomiting. On examination, there's a guarding was present in the upper epigastrium. Chest X-ray was normal. What is the next step? It's again a simple question. We have to remember one basic rule for this question, which is a standard rule we follow in our clinical practice also. Any patient once comes to us with the pain epigastric region, remember. Any patient if comes to us with a pain epigastric region radiating to back, or any patient once comes to us with a pain epigastric region radiating to back, we know we have to rule out acute pancreatitis. First, we always rule out acute pancreatitis. But if any patient comes to us with a pain epigastric region with features of peritonitis, remember as a rule, any patient if comes to us with a pain epigastric region with features of peritonitis, we are supposed to rule out always two things. One is peptic ulcer perforation, and second is acute pancreatitis. And remember, always first we rule out peptic ulcer perforation. Always first we rule out a peptic ulcer perforation, and for that we do a chest X-ray. And for acute pancreatitis, we do amylase and lipase. And in this given patient, chest X-ray is already normal. So the answer is serum lipase. Right? So acute pancreatitis, peptic ulcer perforation, biliary system is a very important thing for INICET exam again per se. So answer this now. It's a good question. Let me first tell you the theoretical points about it. The first investigation in patient with a biliary injury is ultrasound or CT. If you have to answer one, both ultrasound and CT both are there, as per the latest, the better answer is CT. Investigation of choice, if asked, it is MRCP. The best investigation, if asked, it is ERCP, because we can have a therapeutic intent also there with ERCP. Most sensitive, you all know, is HIDA scan. Most sensitive, you all know, is HIDA scan. So this is a very favorite question of the INICET examiners. And remember, whenever there is a biliary injury, safe cholecystectomy will not have a biliary injury, but if the surgeon is not following a safe cholecystectomy protocol, there is a risk of biliary injury. So if in a biliary injury, there can be two scenarios. One is injury happened intraoperatively and the surgeon knows. Intraoperative management, where the surgeon has the injury happened and the surgeon knows that the injury happened. And another is injury happened and the surgeon doesn't know that the injury happened. So in intraoperative management, you have to convert this procedure to open, and if it's a minor injury, do a primary repair over T-tube. If it's a major injury, you should do preferably Roux-en-Y hepatico-jejunostomy. In a post-operative management, the patient will come to you the features of biliary peritonitis. Patient will come to you with features of biliary peritonitis, having pain in the right upper abdomen, having vomiting also. When you examine, there will be tenderness in the right hypochondrium. Pulse also will be on the higher side. Patient can have a pain radiating to the right shoulder. So the first investigation you are going to do is LFTs, biochemical, and imaging. Ultrasound commonly we do, but better they say is CT scan. So better is CT scan if you are suspecting a biliary injury, but commonly we are doing ultrasound because it is readily available. If there is a collection found, there is a collection there, you have to first put in a drain. You have to do a percutaneous drainage, and after percutaneous drainage, you are supposed to do a MRCP to know the extent of injury, and then in most of the cases, we may need to do a ERCP and put a stent. HIDA scan is the most sensitive though, but usually it's not there in the clinical scenario. So this is a management of a biliary injury, which is again a very important question for our exam. Now answer the next question. I've already discussed the protocol of the things in this. So you should be able to answer. Sir, in the question they asked investigation, then why not the HIDA scan? They haven't asked the next management. The question is, Godavari, about a best. Question is about the most helpful. Question is about a most helpful, and the most helpful is one which can diagnose also and which can treat it also. So that will be ERCP, no? So it's a simple question now. Answer is type 3 eclasia cardia. Now answer this question. This is the last question, guys. So answer this. Identify the procedure. It's a Thiersch encircling procedure. So what is important for us in a rectal prolapse? What are the perineal procedures? Quickly, guys, I expect an answer from you. Tell me what are the names of the perineal procedures in rectal prolapse. Quickly tell me the names of procedures which are done perineally in a rectal prolapse. Very good, ABC. Pratt says, sir, please write exam for me. I would love to do that. but I can't do na. If I could. Deloms, Altermere and Thirish. Very good. Deloms, Altermere and Thirish, Wells, Ripstein and a Goldberg rectopexy or anterior rectopexy are the abdominal procedures. So answer is Thirish, encircling procedure. So this is all from my side. See guys, as I have been saying this many time I say this, I feel personally, if you ask me, INICET exam is more doable if we know the pattern, understand the pattern, and we get a good conceptual hold on those topics. In NEET, the array of questions are there from the various topics, but in INICET, more commonly, by and large, there are set topics, but then they go in depth in those topics. That is why I didn't just tell you the what is be safe and what is this bailout. I wanted you to understand that, so that when a question like in sepsis guidelines, I could have easily mentioned this is give 3, this is give take 3, but then I wanted you to understand that, so that when a question comes, I tried my level best to make you understand. I don't know how far I was successful in that, but then this is something with which they actually go in depth and check. So they frame a clinical scenario type of questions to you, and if you have the in-depth understanding, you in a better position. But then all of you say AIMS examination, so if please stick to those topics which are asked in that and go in depth. Now we don't have a time to go in depth. Whatever we have done now, do the revisions there and focus now in the last phase more on the volatile topics. So concept understanding you already had now. Now focus on those volatile topics which we tend to forget. Pharma, micro, biochemistry, these are some volatile subjects, and then these anesthesia, skin, these are short subject, but then they carry a very high, in a way that the answer, if you remember, the answer most of the time. But in those topics which are concept based like surgery, medicine, these are concept based subjects. So in that, if you have a good conceptual understanding, you will be able to answer easily. But then now in this phase, I would suggest focus more on the volatile topics than the other things. So this is all from my side. If there is any doubt or anything there, you can always reach out to me in our DBMCI Premier group is there. You can ask questions there, or you can ask a question directly to me in my Telegram group. There is a group there, with surgery by Dr. Jay Arora name there. But then in that, you can't ask a question because I've at present closed that group. I've opened it for some time, but then there was all promotional things started. So you can direct message me there. I try my level best most of the time, despite my busy schedule, that I answer the queries which the students are asking. So this is all from my side. Just stay calm. See, this is a very important thing for you to, at this last moment, you have worked hard for all these years. All this time you have been working hard. At the last moment, if you lose your sanity, if you get jittery, if you get anxious or apprehensive, whatever you will, forget that. So please stay calm, have faith in your, hard work, have faith in your, the way you have studied for all this time with sincerity. And if you have worked hard and you have worked with sincerity, you will definitely get rewarded. So please try to keep your head calm. Don't give yourself a target which is not doable. Give yourself target which you can achieve, and stay content with that and focus on the volatile things. So this is all from my side, and all the best for your INICET exam. I have done last 5-year papers. Should I do more papers or revise those only? So if you have done the last 5-year PYQs, the topics which you think are the things which you're slipping on from your mind and you're forgetting, now focus on those topics and the volatile subjects. You're done with the previous year questions, so I think you should better do the revision of the volatile things. Manisha says, sir, in second last question, some sources have answered it at MRCP bring most useful as ERCP is invasive. Yes, ERCP is invasive, but the question is not about invasive or the non-invasive thing. It is about most helpful. The most helpful is going to be one which has an advantage of a therapeutic thing there. That is why ERCP, though most helpful, still not a investigation of choice. It is not the next step after ultrasound or CT. It is the MRCP now, right? That is the basic reason for that invasive part. But the question is not about that. Question is about the most helpful. So all the best, guys, and stay calm. Just keep your head relaxed. This is the advice which you should listen to and follow. All the best. Bye-bye.